Okay, John, testing, testing. Can you hear me? You wanted to check for the audio. Can you hear me?
Can you hear me now, Joanne?
Hi, John. Can you hear me?
Okay, I can hear you.
Yes,
You
perfect.
can hear me?
Yes, perfectly. No problem.
Okay.
Yeah.
Okay, thank you, Joanne.
No problem. No problem. Good luck.
All right, this was Palm Beach. We have break 15 minutes. Break 15 minutes was Palm Beach.
John. Hi, John Bennett. How are you?
Hey, hi, can you hear me?
Yes, I can hear you well. Can you hear me too?
Yes.
Okay, great. I will try my. Is it quite okay? The camera is okay as well. Okay,
Yeah,
it is.
you can't see my head. I'm on. Yeah, okay. Where's Sam? Sam coming?
He told me that he will join maybe after 7 minutes. Okay,
Okay.
that's great.
Are
So
you gonna
maybe I will
present?
try to find earpiece to have better voice because it is quite hard to hear you well. Okay.
Okay. Does everyone know how to screen share? You know how to screen share, right?
I will not present. I will moderate, so I don't need to share my screen. Anyway, I
Yeah.
will.
Okay. How about the other guys? They know how to
I
screen
think
share.
they know how to share it because.
Because we can go over it now. We can go over it now if you want.
Yes, when they join, we can
Okay.
ask
Just
them
let me know.
if
Let
they
me
want
know.
to
Okay.
do. Sorry.
Okay.
Okay. Just a minute, and I will come back. Okay.
Okay. Okay.
Mushrooms, man, get some help on it.
John, is it okay right now? Can you hear me?
Yes.
Great. Okay. Sameh will join soon. I text him. And
Okay.
now we are waiting for the panel.
Okay.
Okay, that's great. John, you will record this webinar and you will put it on your YouTube channel, right?
Right.
Great.
It's on YouTube now. Hey, Dora, how are you doing?
I'm doing great. How are you doing?
How are things in Pakistan?
Just a moment. Uh,
You got an extra set of headphones? Just gotta get some headphones. Yeah, you got some headphones?
Hi, someone listen me? Doctor,
Yes, I can hear you.
I'm here. I'm waiting now.
Yes, we'll start after around 13 minutes, inshallah.
Inshallah. Assalamu alaikum.
Alaikum assalam wa rahmatullah.
Shukran.
Afwan, I think it is important for the attendees to mute themselves and kindly we can as well close the video because it may improve the transmission and the internet flow during the meeting, and this will be much better for the meeting performance. And we are happy to have you all between us. Today is an very nice event and very nice time. Actually, in the Middle East and in the Arabic countries, we are celebrating Eid al-Adha.
Yes, of course.
Yes, the big feast, and today is the second day. So
Yes.
it is the holy times actually, and we have a very
Yes, of course.
besonder faculty today in our meeting.
Yes, today we are free also.
Yes.
We have not usually work, only emergency maybe.
Yes. Great.
Thank you.
You're welcome.
you.
From which country you are?
I am from Uzbekistan, but I am working in Iran.
Okay, great. Good luck and have a nice days, brother.
Yes, we are glad meeting from chat.
Yes, thank you very much.
Okay, good luck.
Thank you. See you.
Hello.
Dr. Sarat, hello. How are you?
Good morning. How are you?
I'm fine. This is Mohammed Khattab from Egypt. Nice to have you here between us presenting your experience at this nice time and nice webinar with Dr. Sameh.
Yeah, thank you very much.
Are you familiar with Zoom? Of course,
Yes.
you know how to share the screen, how to stop sharing, how to yes, to manage the presentation. That's great.
Hello. Hello. Can you hear me, Dr. Mohammed?
Yes, Dr. Sarat, I can hear you.
So in how many minutes will we be starting?
We'll start after 10 minutes from now.
Okay, perfect. So I'm keeping myself on mute. So if you have anything to ask me, I will unmute myself. Is that okay?
Okay, it is okay.
Thank you.
You're welcome. Hello, Dr.
Hi.
Abida Shah. Hi,
Yes.
how are you?
Fine.
Nice to have you here between us in this webinar.
Thank you. Thank you for the invitation.
You are most welcome, brother. Regarding how to use the Zoom application in sharing your presentation, it is quite okay for you, huh?
Yes, yes, no problem.
Great. Dr. Sarat Chandra is joined already, and we are waiting for Dr. Atul Gwel.
Yes.
And for Samah, I think Samah will join soon as well.
Okay, that's good.
And Dr. Sushil Patkar.
Yes.
Dr. Mohammed,
Yes, Dr. Sarat.
can you tell me how to share my audio on the video?
Simply while you are sharing your screen, we can see your videos.
Yeah, but how do I share the audio already on the video?
The audio? It is.
Yeah, it's a recorded audio and video.
We can hear it. I used when there is video on the presentation, we can hear the audio as well.
Can I make it?
You can try it right now.
Okay.
You can share your screen and try to play the video and
Okay.
check if the voice is okay.
So can you see my screen?
Yes, using wiring technique for DCCR. But we cannot hear the video, the audio.
It is based on the principle of first distracting the joints using.
Yes, we can hear it.
On the left lower image. This corrects the basilar invagination, but not the AAD or the cervical.
Can you hear it?
Yes.
Deformity. Following this, compressive forces.
Okay, great.
Great, we can hear it.
Okay, good. So let me stop sharing.
Great.
So Dr. Abida has joined.
Yes, sir.
Good evening. How are you?
Fine, sir. How are you?
Yeah, good. So can I share it once more time? I'll just
Yes.
want to ensure.
Yes, please.
All right, pay attention, please pay attention. Good morning, everybody. Good morning. I'm Operator Couch Rami. I'm driving the schedule number 1018. That's schedule going to the final destination with this bus is New York. We have stops for Pierce, Kissimmee, Orlando. In Orlando, if you have reboarding pass 150, stay with the same bus. This bus continue to Daytona Beach, San Augustine, Jacksonville, Savannah, Florence, Fayetteville, Raleigh, and Delaware, and New York.
We can hear the audio, but it looks like it is from airplane.
Applied between the OC1 and C2 as shown by red arrows, and this leads to the correction of both residual basilar invagination and.
Are you able to hear?
Yes, we can hear it here. Okay.
Oh.
Hello. Good day, everybody. I'm hosting this show on the behalf of Neurosurgical.tv.
Hello, Noor.
Yeah, hi, how are you doing?
I'm
just
fine.
on behalf of TV, I'm honored to be hosting this.
You are more than welcome, Noor.
Thank you.
Hello, Professor Dr. Mohammed Khattab.
Yes.
Do you hear me?
Yes, I can hear.
My name is Ahmed Asser. I was with you, sir, in previous spinal surgery in Hilmiya Military Hospital.
Ah, yes.
It is a great honor for me.
Welcome, Ahmed.
Good evening, good evening, sir.
You are more than welcome, Ahmed.
Thank you very much. Thank you. Thank you.
Okay. No?
Hello. Hello, everybody.
Hello, Dr. Atul Guel. Hi,
Yeah.
how are you? This is
How
Mohammed
are you?
Khattab from Egypt.
Nice to meet you.
Nice to meet you.
I can see number of people here on the screen.
Yes, we have 74 participants till now.
Okay. Yeah, I can see.
And Dr. Samah. Hi, Samah. How are you?
Hi, how are you?
Happy Eid, Samah.
Happy Eid, my dear professor. Thanks all for your coming. You are always most supportive. Thank you.
You are more than welcome, brother.
Thank you, sir.
So we are waiting for the last speaker, right?
Okay.
Dr. Sushil Patkar.
I will remind him just now.
Okay, please.
Good evening, my big brother, Dr. Samah.
Alan, Dr. Ahmed. He is doing message. He's sending message to our friend Sushil Patkar.
Okay.
Our dear Professor Batkar will join us in just 5 minutes.
Okay, shall we start, Samah? His presentation will be at the end of this meeting, so we can start. Or what do you think?
Okay. Okay, Sam.
Okay?
Okay.
Great. So, Bismillah ar-Rahman ar-Rahim. In these nice days, I'd like to welcome you all on this first webinar for the Egyptian and World Virtual Neurosurgery Community Academy. And I'm glad to have a special faculty in this webinar. We have very distinguished faculty from India. Our dear professors, Dr. Abida Shah, Dr. Atul Goel, Dr. Sushil Patkar, and Dr. P. Sarat Chandra. And today we have a special event focusing on the occipitocervical junction. And we'll start this meeting by introducing the Egyptian and the World Neurosurgery virtual community by our dear Dr. Samah Al-Morsi. neurosurgeon specialist and the administrator of the Egyptian and World Neurosurgery virtual community. Dr. Sameh, please go ahead.
Thank you. Dear Professor, I have started shared my screen. Is it okay now?
Yes, please. We can see it quite clear, Dr. Sameh.
And sound is good?
Yes.
Okay. Greetings for all of you. It's a great day to meet a lot of our colleagues in the family today. Dear colleagues and professors, I am honored today to be with you and to start a new step in Ewens Academy future. Please let me introduce you a short presentation to inform you more about Ewens. Ewens Academy is abbreviation of Egyptian and World Neurosurgeons Community. Started our online activities for more than 4 years. Ewens is the biggest free online platform for neurological surgeons. What makes Ewens unique is that it is a handmade piece of art that every one of its members put a game to this piece to get final picture that we have today. Joining Ewens Academy is like gathering with big family that you care about and they care about you more. We started by local group on WhatsApp, then still developing on Telegram till we reached 33 groups, each of which has different mission to improve our skills in neurological and spine surgery. Ewens is divided mainly into main groups, study groups, research learning groups, clinical groups, and statistical groups. What makes us more special is that it's always a collaborative work. Each member is highly precious for us. He has to participate even with his little knowledge to learn and add more information to his colleagues. We are highly selective about our members by double selection method to be sure that everyone is related to our specialty. We follow an innovative administration methods that everyone can share in making decisions about in step. He can also suggest the methods that help him more in advancing his skills. And we all as members help him to reach his target. We follow newest statistical methods to guide us in planning for future and decision making. The innovative method of moderation of these groups and high quality content encouraged our colleagues to join us. Till now, we reached more than 16,000 members in 33 groups after subtraction of 30% of overlapping membership between groups. And this is part of our main group statistics that we can gain from automatically statistical processed method. We give which give us a lot of information about members' activities and how they play a great role in building up of Ewens. It's not members number only that we have. But if we talk about numbers that we have in these groups, we will talk all of the day. We have plan for doing a rank for our groups every 3 months. Every 3 months since we started events to guide our planning and to get more recommendation from our members. Last rank was in June and they recommend us to start our own series of webinars. That's why we are here now. Please can you mute? At last, on behalf of Owens Virtual Academy, I'd like to thank you for your support and helping in settling up this amazing platform that make us so closer and give us respectable scientific community that we all are proud of it. Special thanks for our mentors, speakers who have accepted our invitation to join our ceremony. Other special thanks for our teacher, Professor Atul Goel, our teacher that I still keeping his positive and encouraging response for my email about his his personal preliminary approval of attending our previous second physical meeting in Amsterdam last year. Unfortunately, we prepared this year to our third physical meeting, but it was cancelled because of COVID. We have about 300 members who were interested in joining us, and 79 were confirming attendance. We hope next year all of you will be with us in our next physical meeting. Thanks again for our professor speakers, and their efforts for learning are highly appreciated. And thanks for all of you for attendance. I will not introduce our honorable guest speakers today, as they are highly famous and all of us know them well. And now I will introduce our Professor Muhammad Khattab to moderate this session that we will all enjoy it. Professor Muhammad is an orthospine professor of Ain Shams University with well-known great efforts here in Egypt to learn our colleagues. Thank you. Would you start session, dear Professor Muhammad, please?
Thank you.
Yes, sir.
Welcome, Noor. You want to say something, Noor? Huh?
No, sir, I just want to say that I'm really honored to be moderating on the behalf of neurosurgical.tv. I will be just trying to coordinate with you on the behalf of neurosurgical.tv. I'm really honored to be a part of this, and I want to introduce the moderator, Professor Muhammad Al-Khattabi, Professor of Ain Shams University in neurosurgery, and I'm really glad to be announcing the all of the speakers, which are so eminent and they do not need any formal introduction, but we are honored to be introducing Professor Atul Goel and Professor Abida Shah and Professor Muhammad Fauzi and Professor Sarah Chandra and Professor Sushil Patkar as our respected speakers. So thank you again for giving me your time, and I'm honored to be in this class. Thank you.
You are more than welcome, Noor. Thank you very much for sharing your activity with us. That's great honor for us. Thank you, Dr. Sameh, for your presentation and for your initiatives and your enthusiasm to spread and exchange knowledge between spine practitioners and between orthopedics and the neurosurgeons as well. That's really a great honor to have such gathering in such days in this time, focusing on highly specialized area, which is the occipito-cervical junction. And it is your first webinar focusing on spine surgery. And the first presentation that I am happy to present, Dr. Abida Shah from Mumbai, India. Dr. Abida Shah will present a historical and current perspective on basilar invagination. Dr. Abida Shah, we are waiting for your presentation. Kindly share it with us. Thank you very much.
Thank you, Dr. Mohammed. I'll just share my screen now. Can you see it?
Yes, we can see it, Abida.
Okay.
Great.
Good evening, everybody. And I'm going to start this spine webinar series of your society. And I'm very happy to be here. And I thank you for the invitation. And we're going to talk about basilar invagination. So the entity of basilar invagination has been an enigma, for a long, long time. And you can compare it to this Enigma machine. I'm not sure how many of you are aware of this. This was used by Nazis in the World War II to code their activities. It was only later when the British mathematician Alan Turing formed this other machine, Bombay, that they could decipher the code. So the history of basilar invagination has been a mystery to all of us, and it has been decoded gradually. And the main person that has been involved in this decoding is our very honored speaker with us today, Professor Atul Goel. So I'm going to go over the history of basilar invagination, how we were managing it before, and now how we are managing it. So earlier there was an era of decompression, then there was an era of decompression and fixation, and now that we are in this era of craniovertebral realignment and only stabilization. So basilar invagination, the first accounts of this entity was given by Ackermann in 1790. He saw this in a lot of cretins in the Alps, and he associated basilar invagination with cretinism. It is not surprising that this happened because, as you see, a specific feature of cretinism is the short body height, is the short head, is the short neck. So it is very easy to understand how we mistook this basilar invagination to be associated with cretinism. In 1855, the term was first coined as impressio basio cranii by Retzius and Burke. So as you can see here, this is the modern day patient of basilar invagination. You can see the short head, the short neck, the short spine, the short stature. This is the patient's brother. If you compare him, they're real brothers. You can see the difference in height. You can see the short neck. And these are the hallmarks of basilar invagination as we know it now. So what are these entities? Virchow coined these terms, platybasia and basilar invagination. For a long, long time, they were used interchangeably. Platybasia basically is an abnormal flattening of the base of the skull. And basilar invagination is prolapse of the vertebral column into the skull. So it is as if, this is as it was said by Chamberlain, it is as though the weight of the head has caused the ears to approach the shoulders, while the cervical spine, refusing to be shortened, has pushed the floor of the posterior fossa upward into the brain space. So this is one of the first papers that discussed basilar impression or basilar invagination, or at that time also called platybasia, and discussed its pathophysiology and some aspects of management. So what did Chamberlain do in those early years? In 1939, he treated 2 patients with a suboccipital decompression and upper cervical laminectomy. This was followed suit by many others, but the results were variable. They had successes in a very few patients, and most of the patients were faced with severe morbidity and mortality. So now we come to the year 1964. Even though the first case of basilar invagination was diagnosed by Schuller in 1911 by radiologically. For a long time, basilar invagination remained only anatomic and radiologic curiosities. They were diagnosed radiologically, they were pathophysiologically studied, but there was no management for this condition because all the attempts at management, be it decompression, be it observation, be it immobilization, did not have any great results. So this is from our department in 1964, that this was the first account on a paper with craniovertebral anomalies. As you know that this craniovertebral junction anomalies are very common in our country, and the whole pathophysiology has been unraveled here. So let us start. In 1998, Professor Goel classified basilar invagination into two groups, group 1 and group 2 in this paper. The classification was based on the presence or absence of Chiari formation. So if the patient did not have Chiari, it was classified as group 1. If the patient had Chiari, it was classified as group 2. What was the pathology suspected to be? That there was, in group 1, there is direct compression of the brainstem by the odontoid process. And in group 2, there is a reduction in the posterior cranial fossa volume. So the management for this entity suggested was transoral surgery for group 1. Sometimes it was combined with a fixation. And for group 2, only a posterior fossa bony decompression was recommended. Only a bony decompression was recommended, and the dura, it was recommended by sir that you do not need to open the dura. Only a bony decompression is sufficient. And this was the practice that was carried on for quite some time. The treatment of the entity was based on the premise that it is a developmental anomaly and it is a fixed anomaly, that decompression should suffice. This was the premise, and small posterior fossa was thought to be responsible for the Chiari malformation and all its clinical implications. However, the results that were obtained with this form of treatment were not satisfactory. There were a few successes, but also the morbidity continued to remain high, and not all the questions were answered, and the entity of basilar invagination still remained an enigma. In 2004, there was this landmark article on the treatment of basilar invagination by distraction and fixation and craniovertebral realignment. In this paper, again, as the understanding increased, Dr. Goel divided basilar invagination into two groups, group A and group B. Now the Chiari was not considered into the classification. Group A basilar invagination was that when the odontoid prolapsed into the skull base, as you can see here, it crossed the Chamberlain line and it crossed the Wackenham line. So this was group A basilar invagination. And you had group B basilar invagination, in which the whole system, craniovertebral junction system, moved up. The odontoid process crossed the Chamberlain's line, but it did not cross the Wackenham's line. So this was group A basilar invagination and this was group B. Either of them could have Chiari malformation. So this concept has revolutionized the treatment of basilar invagination. The pathology of basilar invagination is now thought to be mechanical instability. It is related to the joints being abnormally inclined, as you can see in these various images, that some of these joints are vertically aligned, some of these joints are obliquely aligned, and this is abnormal. And the entity is not a fixed entity. Basilar invagination is not a fixed abnormality. The joints are mobile, or not only mobile, but hypermobile. And the treatment for this entity is atlantoaxial stabilization. So basilar invagination is a disease of the atlantoaxial joint. It is a dynamic and progressive process. There is an increasing slippage of the atlas over the axis over a period of time. This process of slippage may be exacerbated by trauma. So it was likened to your lumbosacral listhesis. Just as you have L5 over S1 listhesis, here you have the facet of atlas that listhesis over the facet of axis, and this is your transatlantic odonto-occipital listhesis. That is basilar invagination. So this was the treatment for this entity. You have plate and screw fixation for atlantoaxial stabilization, and this was extrapolated to basilar invagination. And the method used was a direct application of screws to the atlas and axis. You open up the joint. There was denuding of the articular cartilage, stuffing of the joint with bone chips, and a direct distraction and fixation of the craniovertebral junction for basilar invagination. As you can see here, this is a case of group A basilar invagination. You can see that the odontoid has prolapsed quite significantly into the skull base. The joints are abnormally inclined, and this patient has been treated with a craniovertebral realignment by opening the joint, putting bone graft into the joint, and then fixing the region by a C1 lateral mass and C2 pedicle screw fixation. And you can see the post-operative craniovertebral realignment of the region. Sometimes instead of bone graft, we also use spacers in the region, but the use has decreased over the years, and now the indications for spacers are very few. So now these are some various cases that you can see. This is an MRI showing the basilar invagination. You can see how the joint is abnormally inclined here. It is quite oblique, and this is after fixation. The basilar invagination has reduced, and you can see that the joints are also back into good position. This is another patient with severe basilar invagination, and you can see how the configuration of the joints here are. The atlas is assimilated. Here you can see that the C2 joint is nearly practically touching the occipital region here, and this is after fixation. This is another patient with basilar invagination, and you can see the severe cord compression here. You can see the hypermobile joints, the joint that is listhesing over the joint of C2, and this is after fixation. This is another patient with good craniovertebral realignment after atlantoaxial stabilization. No decompression, only atlantoaxial fixation. So what we observed after fixation is that there was a reversal of a lot of long-standing musculoskeletal changes and neural changes after the stabilization of the craniovertebral junction. And we published this in 2009. As you can see here, this is a case preoperative image of the patient with basilar invagination. You can see how the neck is short. He has a torticollis here. This is after reduction. This is immediately after surgery. You can see that the neck has straightened significantly, and the neck has also become quite long. So this is an immediate change in the musculoskeletal abnormality that you can observe in patients after treatment of basilar invagination. This is another patient. You can see the marked torticollis that he had, the short neck, which has reversed in the immediate post-operative period, and the neck has become straight and long. So these are again a few examples. I'll quickly just run through them. This is, you can see the severe invagination, and this is the post-operative realignment. Here again, you can see how the odontoid process is practically touching the back of the skull, and the joint is practically vertically down, and listhus is completely spondyloctosed over the C2 facet, and this is after fixation. So this, you can see that the musculoskeletal abnormalities have reversed here. The craniovertebral junction is nicely realigned, and the joint is beautifully fixed. So as you are seeing the musculoskeletal changes and some of these cases of basilar invagination, there are also some neural changes that reverse after fixation of the craniovertebral region. So you can see here, there is a patient of group A basilar invagination. Here, there is a Chiari here. There is also a syringomyelia. This is the joint, and after fixation, you can see that the region is realigned. This is immediately within 48 hours of surgery, the Chiari has disappeared and the syrinx has reduced. So there are two components, the musculoskeletal abnormalities and the neural abnormalities, and both reverse after fixation. And the patient has a remarkable clinical improvement. So you can see here, this is another patient with syringomyelia with a basilar invagination. Here you can see this is inflection, this is an extension. This is after fixation, the craniovertebral realignment. And you can see here in the immediate post-operative period that the syrinx has reduced and the region is completely realigned. So these are a few complex cases of basilar invagination where you see that there is a vertical movement here. On flexion, the odontoid is going up. On extension, the odontoid is coming down. Also, you can see in the CT scan that the vertebral artery has an anomalous course in this side. And here the C2 pedicle is very short. But as your experience increases and as you train to do these cases, you are able to do a good craniovertebral realignment with this procedure. So this is another patient. Here you can see that the malformed craniovertebral junction, the abnormal joints, and this is after craniovertebral stabilization. Now there are patients that we have treated with who have come to us with a failed occipitocervical fixation. Here you can see that the someone has treated this patient with a occipitocervical fixation, but the joints are still abnormal. There is no bone graft in this joint, and the patient still has persistent basilar invagination. So we revised surgery in this patient, and now you can see that the craniovertebral junction has realigned, the joints have realigned, and there is a beautiful fixation, and the patient has remarkably improved in his symptoms. So this was a recent paper on 510 cases of group A basilar invagination, where we studied the radiological changes that occur in this group of patients. As we progressed further in the understanding of basilar invagination, it was realized that not only group A, but also group B is associated with atlantoaxial instability. And we started treating patients with this. Our understanding was based on this classification of facetal alignment, which I will show you. So this is group A basilar invagination. This is where the facet of atlas is over the facet of axis, and we call this as type 1 atlantoaxial instability. And this is type 1, and this is typically associated in acute cases and in cases with group A basilar invagination. Then there was another kind of instability that was noted, in which the facet of atlas goes behind the facet of axis, and we call this as type 2 atlantoaxial facetal instability, and it was also seen in a lot of these patients. And there was a third group of patients where there was no, this is not the one, but where there was no malalignment of the facets, they were in alignment, and we call this as type 3. This is another type 2, and we call this both type 2 and type 3 as central atlantoaxial instability. So this was a paper where atlantoaxial fixation for basilar invagination without any obvious atlantoaxial change in the atlantodental interval or obvious atlantoaxial instability, group B basilar invagination was treated with atlantoaxial fixation. So these are a few examples. Here you can see that the odontoid is quite up. It is not beyond the Wackenheim's line. The facets, this is type 3, where the facets are alignment. There is no manifest atlantoaxial instability. There is no change in the atlantodental interval. There is a Chiari malformation here. We have treated this patient with atlantoaxial fixation, no decompression, and the patient has remarkably improved. Earlier for group B, we had recommended a posterior fossa decompression, but over the years, the philosophy has changed, and now we no longer do a posterior fossa decompression, only an atlantoaxial fixation. So you can see another patient here. This is the type 3 atlantoaxial instability. This is the type group B basilar invagination. As you can see here, the odontoid is above the Chamberlain's line, and this is the atlantoaxial fixation. This is another patient with Chiari, with a syrinx, with a group B basilar invagination. There is no change in the atlantodental interval. This is flexion, this is extension. The joints are here in alignment, and you can see the atlantoaxial fixation. And this is after some time, a delayed scan showing the reduction in the syringomyelia and the resolution of the Chiari formation. So, and the patient, apart from this, the patient shows remarkable clinical improvement from the day of the surgery. So there's another patient with group B basilar invagination where the facets are in alignment. There's a Chiari formation, and this is the fixation. This is another patient. So now we have a lot of patients with these kind of abnormalities. The only difficulty is that the joints are very high, and it is very difficult sometimes to reach it. But obviously, if you have to give a good clinical result to these patients, you have to learn to do this. So this is another patient with a severe basilar invagination. You can see how high the odontoid is, and the joints are in alignment here, again very high. And this is a 3D model that we have constructed for this. I will discuss this subsequently. And this is the atlantoaxial fixation and the remarkable clinical improvement in this patient. Another patient with Chiari, syringomyelia, group B basilar invagination. And you can see in the delayed post period, the Chiari has resolved, the syrinx has markedly reduced in size. And another patient with Chiari and syrinx and group B basilar invagination. In this, we have used a spacer, as you can see here. This is the spacer in the C1, C2 joint and the plate and screw fixation. This is another patient with group B basilar invagination. The Chiari, you can see in the post-operative period, the Chiari has reduced, the syrinx has markedly reduced. And this is the fixation, only fixation, no decompression. So this is a short video of the technique, just some salient points I will like to show you. So before I start, this is the C2 spinous process. This is the C2 lamina. This is the C2 pedicle. And this is on the left side of the patient. This is cranial and this is caudal. So first I would like to drill, after exposing the region, do a subperiosteal dissection, separate the muscles from the C2 spinous process. Then you come on the lamina of C2 and then you go to the C1, C2 joint. So this is the lamina of C2. This is the pedicle of C2. And this is the C1, C2 joint. See here. Now an osteotome is being inserted into the joint here. This is the C2 facet and this is the C1 facet. There is some tissue over this region, which I will remove now. So this osteotome is inserted and turned, and we have distracted the C1, C2 joint. And here you can see the C1 facet better now. And some tissue I am removing from the C1 facet. The problem in craniovertebral junction surgery, there are two problems mainly that have to be overcome, that have to be learned. That is the handling of the vertebral artery and the handling of the venous bleeding. So here the joint is being exposed properly now. The articular cartilage on both the C1 and C2 surfaces are being denuded to make a raw area to aid the subsequent fusion. So this is the first pilot hole that is being drilled into the C1 facet. And the direction is medial and in a slightly cranially. C1 lateral mass is a huge bone. It is a good cortical bone, and it gives good purchase for the C1 screw. So these are bone chips that are harvested from the iliac crest that are being stuffed into the C1, C2 joint. Sometimes we use spacers, but earlier we used to use, now we hardly use any spacers. We mostly use these bone chips into the C1, C2 joint. So you stuff the C1, C2 joint with bone chips, and this greatly enhances fusion. Now the C1 screw with the plate is being put in the C1 facet. So after putting the C1 screw, you have to make an area on the C2 lamina for the plate to sit and find a good point for your C2 pedicle screw insertion. So in cases with basilar invagination, the joints are very high and sometimes that makes the surgery difficult. So now the point is selected for C2 screw insertion. As you can see, it is in the most superior and medial part of the C2 pedicle. The C2 lamina and pars and pedicle area is being drilled here so that the plate fits snugly into this region. And now I have put the plate here to cover the C2 hole where the screw will now be inserted. And now the C2 and C1 screws are tightened. The C2 screw is generally tightened first in cases of basilar invagination, and then which causes a reduction of the basilar invagination. And then the C1 screw is tightened. So after both the screws are tightened, the spinous process is denuded here, and the whole area is drilled to make a raw area for bone graft insertion that is harvested from the iliac crest. So this is on one side, and then after the fixation is done, you go on to the other side. So this is the short video. Also, to make a little surgery helpful for complex craniovertebral junction anomalies, we described these 3D models, 3D printed models, and they have helped us quite a lot for complex craniovertebral junction surgery. As you can see here, this is a case of basilar invagination. You can see the joint here. And if you see the model here, you can see that the vertebral artery here is right on the facet of C1, having an abnormal course. And so what we did is on one side, we did a C1, C2 fixation. On this side, we just inserted a spacer into the C1, C2 joint so that there would, to avoid injury to the vertebral artery. So these models are of the patient's neck size. They are lifelike and you can hold them in the hand. They can keep them next to you during the surgery. And it really helps you to define the bony problems in the craniovertebral junction. This is another patient you can see with basilar invagination, and this is the 3D model which we used, and you can see the realignment here. This is another complex group B basilar invagination where a foramen magnum decompression has been done. This is the 3D CT of the patient. So if you compare the 3D CT with the 3D model, you get a much more better feel with the 3D model where you can define this. You can actually feel the area, and if it's right next to you during surgery, you can also see this and define your planes and get onto the bony junction over here. So this is the fixation. This is another patient where you can see the vertebral artery was abnormal on one side and the surgery was modified accordingly. This is another patient where even though there is a rotatory kind of a dislocation, the atlas is pushed on one side behind. So you can also decide which side of the fixation you want to perform first. So you can do the easier side first and then the more difficult side. You can see both the vertebral arteries are away from the C1, C2 joint. So it becomes relatively safe to do the surgery. And this is the post-surgery craniovertebral realignment. And here you can see the model more clearly. This is another patient where someone had done a foramen magnum decompression earlier for this patient. And you can see the complex anomalies in this region. And this is the 3D model. A lot of foramen magnum rim had been removed along with the C1 and the C2 lamina. So to define this intraoperatively when you're doing a revision surgery, this 3D model helps a lot, and you can find the exact place to get into the C1, C2 joint. And this is after the fixation. So is another patient with where you feel that the vertebral artery may be high riding, but when you actually see the model, you can see that there is good enough space and you can easily go into the C1, C2 joint and do the fixation. So to tell you, basilar invagination, syringomyelia, and Chiari malformation, they are all a spectrum of abnormalities. Just like your musculoskeletal abnormalities, syringomyelia and Chiari formation are neural abnormalities, and all of them have their basic denominator as atlantoaxial instability. So as we more matured in this treatment of craniovertebral junction abnormalities, we realized that atlantoaxial instability is also the cause of Chiari malformation. And I will just show you a few cases. This is a Chiari formation, as we like to call it now, with a syringomyelia. And this is the type 2 facetal instability. And this is post-fixation. You can see the Chiari has resolved. The syrinx has reduced in size. No decompression, only craniovertebral fixation for Chiari malformation. You can see here the Chiari and the syringomyelia. There is no bony abnormality in the craniovertebral junction. And you can see after fixation, the syrinx has gone, the Chiari has resolved. So there is no need of a foramen magnum decompression. This is a group B basilar invagination with a Chiari malformation and syringomyelia. And this is after fixation. And you can see the Chiari is resolved and the syrinx has also reduced in size. So we did a few cases with intraoperative monitoring. And after fixation, we noticed that there was an immediate increase in the motor evoked potential that was seen after our screw fixation on the side, on both the sides. And this is the patient with a Chiari formation. There is a type 2 facetal instability. There is hardly any basilar invagination. And this is after fixation. No decompression, only atlantoaxial fixation. And you can see how the MEPs have increased, and the patient in the post-operative period has done very well. There's another patient where there is only Chiari formation, where there is no craniovertebral junction anomaly. There is a Chiari and syringomyelia, and atlantoaxial fixation has been done. And you can see the MEPs before surgery and the remarkable change in the MEPs after surgery. So this we published recently, and we have got these remarkable results. Clinical results are definite, and we also see this change in the MEPs. So to summarize, basilar invagination, syringomyelia, and Chiari malformation, atlantoaxial instability is the cause. They are nature's protective formation, and they stall or delay the effects of atlantoaxial instability. As the understanding of this entity, basilar invagination, has evolved, it appears that mechanical instability is the cause, and craniovertebral realignment and atlantoaxial fixation is the current management of this anomaly. And the future of treatment of these entities is atlantoaxial stabilization. Occipital fixation is not necessary. A segmental atlantoaxial stabilization is good. Foramen magnum decompression is counterproductive. Transoral and transnasal decompressive surgery for the entity of basilar invagination are historical. Thank you very much.
Thank you so much, madam, for this wonderful informative webinar. Yes, please.
Thank you, Professor Abinda Shah, for accepting our invitation and for very nice presentation. And now we will present our craniocervical pillar, teacher of all of us, Professor Atul Goel, and just please, Professor, we are waiting for you.
Okay, can you see my slide?
It's okay, sir.
You can see my slide, right?
Yes, sir.
Okay. So I will like to present to you my at least 35-year-old work on craniovertebral junction. And Dr. Abida has already summarized to you my concept, and we have been working together for at least last 15 years together. And she has been a very strong worker on craniovertebral junction. You have seen her enthusiasm in her presentation. So I will present to you our modern understanding of craniovertebral junction surgery. There is no question in my mind, no doubt, that there is a complete revolution, complete change in the understanding of craniovertebral junction, not only just basilar invagination, in the entire concept, the treatment of rheumatoid arthritis, treatment of tuberculosis, treatment of basilar invagination, treatment of rotatory dislocation, treatment of lateral dislocation, and so many other things of craniovertebral junction, Chiari malformation, syringomyelia, everything has changed, complete revolution, and I am here to present to you this revolution of craniovertebral junction. Craniovertebral junction surgery is not easy. Don't get the impression that it is easy surgery. It is dangerous, it is difficult, it is complex. You can create very big disaster in this surgery. You can create complication of which to come out of those complications can be absolutely impossible. The patient can be crippled, the whole family can be crippled. On the other hand, if you know how to deal with the craniovertebral junction, if you can stabilize the craniovertebral junction properly, you can give instant instant new life to these unfortunate people. So there is no question that craniovertebral junction in general is a complex subject, but the treatment is quite dramatic, and treatment can be completely revolutionary for the patient and for the whole family. These are the beautiful bones of the craniovertebral junction, atlas and axis. You see, atlantoaxial joint is the most mobile joint of the body. It is round and flat. You see, like no other joint, like sacroiliac joint and atlantoaxial joint. The atlas transverse process, largest transverse process of the whole spine. C2 spinous process, largest spinous process of the whole spine. And more importantly, I am showing you the bone, this C1 facet. If you touch this C1 facet, there is no other bone in the body which is as strong as C1 facet. It is next to teeth. It is the hardest bone of the body. So we have to use this hard bone. The purchase of the screw in C1 facet in the C2 facet are remarkable, strong, and there is no question that screw fixation has now come to here to stay. Atlantoaxial joint is the most mobile joint of the body. Atlantoaxial instability is the most common instability of the whole spine. I must say very clearly, atlantoaxial instability is the most common instability of the whole spine, number one. Atlantoaxial instability is the most under-recognized. We don't know that we are not recognizing atlantoaxial instability. It is the most under-recognized and the most under-treated clinical entity in the subject of entire spine. Anatomy of this region is absolutely critical. We said in our paper a long time ago that vertebral artery has a dynamic relationship with the vertebra, with the bones. You turn the neck, the artery will go up on this side. You turn on the other side, the vertebral artery will go up on this side. So there is a dynamic phenomena, and the whole region is surrounded by huge veins which empty and open and close as the movements occur. So this dynamicity is very important in craniovertebral junction arteries. Facet is the center of movements. Facet is the fulcrum of atlantoaxial movements. Facetal stabilization is the treatment. If you can stabilize the facets, that is the final answer. If you stabilize remote from the facet, like you stabilize the lamina or the spinous process, that is a suboptimal form of stabilization. So we described this technique in the year 1987. You see, 87 was the first case we did. And then, of course, we have a huge number of cases over the period of time. My answer to atlantoaxial instability is open the joint, remove the cartilage, put bone graft in the joint cavity. These three are the most important steps in this operation. If you do not know how to do these three steps, please do not touch craniovertebral junction. You cannot say it is difficult. If it is difficult, we have to learn. And if we have to learn, we can do. Unless we spend time in learning, we cannot do. It is difficult, but open the joint, remove the cartilage, introduce bone graft in the joint, and then do atlantoaxial fixation. That is the treatment. So this was the case that we did actually in 1987. And you see segmental fixation. If you ask me, craniovertebral junction instability is equal to atlantoaxial instability. Craniovertebral junction stabilization is equal to atlantoaxial stabilization. Occipito-atlantal joint is the most stable joint of the body. Occipito-atlantal instability is almost not known. Very, very rare cases of trauma where there is occipito-atlantal instability. Otherwise, this is the most mobile joint and the most unstable joint. I again repeat the three basic steps of this operation. Open the joint, remove the cartilage, introduce the bone graft in the joint, and then do fixation. So this anatomical understanding, as we have heard earlier, is very, very critical. There is C2 ganglion just beyond the atlantoaxial joint. I described this sectioning of C2 ganglion in 1987. I am not saying I'm using C2 ganglion resection today in all cases, but some cases I do use. But this anatomical understanding completely opened the atlantoaxial joint for lateral mass fixation surgery. And in my estimation, it is a complete revolutionary. One step is entire change of gamut of atlantoaxial surgery. Of course, vertebral artery is the most critical issue in atlantoaxial joint surgery. Venous bleeding is the other issue. So these are the issues which we have to know. And in many cases, there are abnormal vertebral artery. In many cases, there is high atlantoaxial joint. But whether it is high, whether it is low, we have to do the operation of segmental atlantoaxial fixation. So this is a mobile dislocation, no controversy. Atlantoaxial fixation is the treatment, no controversy. Mobile flexion you do, there is dislocation, extension, there is reduction, atlantoaxial fixation in reduced position, that is the answer. There is no controversy for several years. This is not a new introduction, this is an old introduction. Only thing that has been introduced is this technique of lateral mass fixation. Earlier, these cases were fused by wire fixation and loops fixation and hooks fixation, but of course, those are now considered, at least by most of the people doing craniovertebral junction, as historical operation. We also discussed double insurance fixation, one screw in C1, one screw like Megal's fixation. So introduction of both these techniques, and not in all cases, not in many cases, in some cases, we do this to reinforce, particularly in cases where there is a high riding vertebral artery. You see high riding vertebral artery, in that case, you go close to the vertebral artery and introduce your screw up. So this is one more patient where there is one screw in C1, one like Megal's technique. Lateral mass facetal fixation is the treatment of atlantoaxial instability. Vertebral artery, as it comes up, it goes medially into the atlantoaxial joint. This loop of the vertebral artery, of course, this is a very dramatic loop. It does not happen like this in most of the cases, but it can happen in some cases like you see here. And this medial loop of the vertebral artery close to atlantoaxial joint can completely demolish your surgery if you introduce the screw, and you can damage the vertebral artery. So that is the worry in all cases, how to handle the vertebral artery. How to expose and how to handle the vertebral artery is an issue which dominates the psyche of a surgeon who is going to operate on these areas. And vertebral arteries can be in various shapes, various sizes, various courses, and you have to know in a very three-dimensional perspective. This understanding is crucial for the surgery of this region. So as we have heard, we described this three-dimensional anatomy of three-dimensional models, which we use quite regularly now, particularly in complex cases. So now you see this beautiful atypical bone. This is, I call, a majestic bone with a crown of dents. There is a facet. This is superior facet. This is inferior facet. Superior facet is anterior, inferior facet is quite posterior. This alignment is unique for C2 vertebra. There is no other vertebra where superior facet is so much in front and inferior facet is so much behind. And also the vertebral artery is in relationship with the superior facet. It comes up and then it comes out of this foramen. So this relationship of vertebral artery in relation to the superior facet has to be very clearly understood before the operation. So this is the model which we made long time ago and published in my article. We made a kind of multiple quadrants, and we use the medial quadrants. And I just want to show you this smallish little video where you see this is the direction of the screw, medial and superior. That is very important. If you put straight down, you can kill the vertebral artery. Medial and superior is the best direction. Now we described, some cases the vertebral artery is high in relationship to the superior facet. But you must remember the inferior facet is not in relationship with the vertebral artery. So when the vertebral artery is high, you can use the inferior facet for screw insertion. So caudally directed inferior facetal, or you can use transfacetal C2-3 screw or C2 screw in the inferior facet, that can be a good option in selected cases where the vertebral artery is quite high. Like in this case, there is high vertebral artery. You may not be able to introduce your screw in this, but you can use this inferior facet, and this can be used. Quite strong fixation can be possible. This is another case. You see there is dislocation and the whole lateral mass is quite destroyed, as you can see. So I have introduced the screw in the inferior facet of C2. The other thing that we recently discussed is that vertebral artery in the foramen can be mobilized. You see, this is the vertebral artery. You can drill on the C2 posterior aspect of the pedicle and mobilize the vertebral artery. So this is the vertebral artery in the C2 pedicle. You can actually mobilize. And I had discussed this in one article recently, where we mobilize the vertebral artery. So you see here, there is the vertebral artery foramen is quite high. And to introduce the screw in the C2 may be quite difficult. But what I do is open this, drill this posterior aspect. See, the bone is very thin. You drill and mobilize it inferiorly, and you can introduce this screw. This is believe me, this is not a difficult procedure, but this is quite worthwhile procedure, because when we land into a vertebral artery in this kind of a situation, we should have an option. Here is another case. You see the vertebral artery is quite high. The pedicle is quite thin. You cannot introduce your screw. So I mobilize the vertebral artery down, and I have introduced the screw in this fashion. Other thing that we described, laminar screws were first described by me in this article in 2004. Spinous process screws, spinolaminar screws, all these things were discussed in our article. So when the vertebral artery groove is high riding, and you cannot introduce your C2 screw, you can use the spinous process or spinolaminar screw. This is the drawing from, this is the picture from my article, which was published in 2004. There are some more, but now I don't use these laminar screws or spinous process screws, because I don't think it is necessary, because I have other options to play with. This was another case. Both sides, the vertebral artery were very high. And during that time, 20 years ago, I may not have been able to do that case, and I used this. But I must tell you, now I do not use this technique of laminar screws, and I 100% of times, no matter what, how the facets are, how high are the facets, 100% of time, I will do C1, C2 fixation. But I know it is difficult. I know that it is not easy. And I know even for me, it is not easy when I'm doing this operation for 35 years. So in that case, you might like to use occipital fixation if you're not able to do, but you must remember that use the strong, solid C1 facet for screw insertion. That is the best. We also introduced this intra-articular implants of the facets for the first time in the literature, initially in the atlantoaxial joint, then of course in the subaxial joints, but these spacers have also become quite popular. These are patented by me in various institutions, including US. And this technique, I call it joint jamming technique. I must say that I don't use this technique very often. Introduction of bone is important in the articular cavity. Spacer is necessary in some selected cases. Like this case, you see the vertebral artery was very high. I could not introduce my screw. So I used this spacer as a technique of fixation. Other side, I used atlantoaxial fixation. The other very difficult technique is transcranial insertion of atlas screw. You see, sometimes the facet of atlas may be very, very high, and you may not be able to introduce your screw in this direction. So I do a small craniectomy in the occipital bone, and then work in this direction to get the facet and then introduce the screw. And of course, C1, C2 screw, if you are able to do, you give a brand new life to the person. You must remember. And if you fail in doing, you can have a person who may not be able to survive for long. And even if he survives, he can survive in a very crippling situation. So this is very high basilar invagination, Chiari malformation. You see the facet of atlas is quite high. So I do a small little craniotomy here, and then I introduce the screw. Then I go the screw. Of course, opening of the joint is necessary, introduction of bone graft is necessary, and then C1, C2 fixation. This is another case. See, the facet of C1 is quite anterior. You cannot introduce your screw, but mobilize the facet. Do a small little craniectomy here, and then introduce the screw in the facet of C1, and you do C1, C2 fixation. As I mentioned, you may not be aware that, but the occipital screws were first described by us in the year 1987. These screws, I was very frequently using these screws, and this construct of occipital C1, C2 screw was described by us in 1987, 33 years ago. And now, of course, I do not use occipital fixation as I mentioned in this article, but I also tell you that C1 fixation screw direct insertion may not be possible by people at least who are not extremely experienced in this subject. You have to be extremely experienced to be able to introduce C1 screw in all these cases. And if you are not able to do, then of course occipital fixation is an option which can be used. So what I describe some kind of dislocation, you see in extension, it is reduction, flexion, it goes. This is called vertical, mobile, and reducible. Vertical. So this was an unusual kind of atlantoaxial dislocation. We also describe lateral dislocation. You see in bifid atlas, bifid, the facets are laterally dislocated. You can see the whole alignment is different. And in trauma, you can have lateral dislocation of the facets when the ring of atlas is broken. So we had introduced this manual realignment, open the joint, realign the facets, and then do fixation. This is remarkable. If you can open the joint, you can realign the facets. We also describe lateral dislocation in cases with tuberculosis where there is destruction of the ring of atlas. Rotatory dislocation, nobody in the world knew how to treat rotatory dislocation. Open the joint, manipulate the facets on both sides, and manual reduction has completely revolutionized the treatment of rotatory dislocation, and you can reduce and you can give new shape and new happiness on the faces of these unfortunate children who are having no symptom other than torticollis, and this can be reduced very effectively and beautifully. Other revolution in the field of craniovertebral junction, I know many of the people are young people in the audience, but many are senior and experienced people doing craniovertebral junction. There is no doubt, and if there is a doubt in anybody's mind, please remove that doubt. This article, which was published as cover page of Journal of Neurosurgery, completely revolutionized the field of craniovertebral junction. It said that there is nothing like irreducible dislocation. Open the joint, manually manipulate the facet, and reduce. There is no question of irreducible dislocation. This article completely revolutionized the field of craniovertebral junction. This was no flexion, extension, no change. So this was a transoral decompression was the treatment for such cases, but open the joint, reduce the dislocation, and realign the craniovertebral junction, realign the craniovertebral junction. Now we have got hundreds of cases like this where realignment is done. Basilar invagination, as Dr. Abida was discussing, is an entity which was never really understood. It was not even a surgical entity in 1970s. After 1970s, there have been some treatment described here and there, but no concrete discussion has been there on this subject. In the year 1990, we discussed these two types of basilar invagination. In one, odontoid process goes up, in one, tonsil comes down. The most important issue in 1998 was that this was considered to be irreducible atlantoaxial dislocation. This was considered to be a fixed dislocation. So as the entity was fixed, the treatment was transoral decompression in this and foramen magnum decompression in this. This was the treatment, and we described this treatment. So there was no confusion in my mind. Decompression was the treatment in 1998. So we discussed that basilar invagination is nothing but atlantoaxial instability like facetal listhesis, like lumbosacral listhesis. Stabilization is the treatment in selected cases. Listhesis is the problem. Stabilization is the treatment. We discussed this, and we introduced a new classification in the year 2004 and divided basilar invagination into two groups. One is where the odontoid goes up. There is a clear evidence of instability. Group B, where the tonsil is coming down, there is no manifest or validated parameters are not showing any atlantoaxial instability. In the year 2004, I described that such patients need decompression. Such patients can be treated by craniovertebral junction realignment, complete revolution in the field of craniovertebral junction and in basilar invagination. You see, there is basilar invagination. These are cases done by me 20 years ago. This is another case where there is open the joint, distract the facet, introduce bone graft in the joint. Instability is the problem. Stabilization is the treatment. Instability is the issue. These are not fixed problems. These are not irreducible dislocation. These are hypermobile pathological dislocation. You can reduce, and you can reduce basilar invagination. This was my first case where I tried this opening of joint, and you can see complete realignment. Transoral surgery is completely not necessary. There is no need for any decompression. So these cases, if there are some senior people in the audience, these cases were treated all over the world at that time by transoral decompression. You will be, I am even surprised that even in several countries today, transoral surgery and transnasal surgery are being done for these cases. I will say completely historic. If you don't want to understand, nobody in the world can help you. If you want to still do decompression, nobody in the world can help you. That is an entirely useless operation. This kind of huge basilar irreducible dislocation can be reduced. Now, another thing I want to tell you is, if the reduction is not complete, it doesn't matter, as long as you have done a solid fixation. Another thing which I want to discuss is a chronic atlantoaxial dislocation. Long-standing atlantoaxial dislocation, there are huge number of natural reparative games that happen. And as we have already heard earlier, short neck, torticollis, Klippel-Feil abnormality, platybasia, bone fusion, assimilation of atlas, C2-3 fusions, bifid arch of atlas, and a host of number of problems are secondary to one issue, and that issue is atlantoaxial instability. You stabilize the atlantoaxial joint, all the issues which are secondary musculoskeletal changes. I think this article also, where I discuss a large number of patients, has been a complete revolution in the field of craniovertebral junction. You can have a long neck, you can have reversal of torticollis in the immediate postoperative phase. There is no need for any osteotomy. Cervical fusion is a protective phenomena. Klippel-Feil abnormality is a protective phenomena. Assimilation of atlas is a protective phenomena. It results in a short neck, and it is a manifestation of long-term neck muscle spasm. And if you have a multi-segment bone fusion, even if there is no compression at the craniovertebral junction, if you see bifid arch of atlas, even when there is no compression at the craniovertebral junction, there is only one treatment which can give new life, complete new life to this patient. And this patient was a very important patient and a very powerful politician's daughter. And you can imagine this patient started breathing properly after surgery and got a new life. If you say there is no compression, I will do some other kind of treatment, you will completely destroy this patient. Do not destroy this patient. This patient needs atlantoaxial stabilization. These bone fusions are secondary to primary atlantoaxial instability. This article, I discussed 190 cases of os odontoideum, and I must tell you, this entity of os odontoideum is not understood in many countries. And many countries still people are doing transoral decompression and occipitocervical fixation. Absolutely not a good operation. You have to, this is a manifestation of atlantoaxial dislocation, and you have to do atlantoaxial stabilization. In my article, we said that this odontoid process is broken by God to help against the compression of the bone of the cord and the dura by the movements. So we have, multiple changes in the cord as a result of ospodontoidium. What is required is atlantoaxial stabilization. Syringomyelia, there are musculoskeletal issues, there are neural issues. Syringomyelia is a neural problem related to atlantoaxial instability, is a protective phenomena. I published this article in 1996, and there is no question in my mind. These are revolution in the field of craniovertebral junction. People were doing shunts and tubes in the syringomyelia 100% of times. But these are secondary protective phenomena. When there is a syringomyelia, there is presence of atlantoaxial instability. You have to stabilize. I want to introduce another revolution in the field of craniovertebral junction, the issue of central or axial atlantoaxial instability. This concept has completely expanded the horizons of craniovertebral junction surgery. Just rapidly see these 3 slides. You see here the facet of atlas is dislocated anterior to the facet of axis. So there is increase in atlantodental space, and there is compression of the craniocervical cord, and there is listhesis, and you have to do stabilization. Now carefully see this. This kind of basilar invagination, the whole world will do foramen magnum decompression. There is no atlantodental interval disturbance. There is no neural compression. But carefully see this facet. This is dislocated behind. This is type 2 dislocation. There is no question. If you do decompression, that is a nonsense operation, according to me. I am using these strong words to give a strong message, to give a clear message that this does not need foramen magnum decompression. If you do decompression, that is a waste of time for the patient and for the surgeon. This patient needs atlantoaxial stabilization. Even when there is no atlantodental interval disturbance, even when there is no facetal abnormality, presence of basilar invagination, presence of Chiari formation, presence of syringomyelia are indicators of an unstable craniovertebral junction, and it merits the need for stabilization. If you have any confusion, please do not keep that confusion, because that confusion will harm your patients. Learn the technique of opening the joint. These are not easy to open. This kind of high facetal C1 is not easy to expose. But if it is not easy, then you make it easy by your hard work and dedication towards this subject. I have published several articles on this subject now over the years. Basilar invagination is always associated with instability. In massive basilar invagination, syringomyelia, Chiari malformation, look at the facets. When facetal abnormalities, there is no question you have to do fixation. Even when the facets are in alignment, you have to do fixation, because Chiari itself is a manifestation of unstable spine. This kind of huge basilar invagination, not easy to do, no question. But if you can do it, you can give new life. Craniovertebral junction operations are not easy. Chiari malformation, basilar invagination, facets are in alignment, no atlantodental interval disturbance, needs atlantoaxial stabilization. So basilar invagination, 100% of times it needs stabilization. And we have published several cases over the years where there have been almost, I don't want to say almost zero complications in the entire series. I'm not saying zero, but there are almost zero. There are some, but you see, this was associated with 100% complications earlier. But if you know how to open the joint, you can give fantastic, fantastic results. So transoral surgery, I have no hesitation to say that we completely demolished this surgery in the history of neurosurgery from the domain of books of neurosurgery. And I am saying today, and I'm saying to this EWNS group, WC group, that there is no question that foramen magnum surgery, decompression surgery is an entirely unnecessary operation and is bound to be eventually turning out to be a historical operation. So basilar invagination, syringomyelia, Chiari malformation are all secondary to one problem, and that problem is atlantoaxial instability. Atlantoaxial instability is the cause of Chiari malformation. Whether there is bone malformation, whether there is basilar invagination or not, they do not need all these kind of decompressions. They need stabilization. Syringomyelia, Chiari malformation, no facetal abnormality, no atlantodental. You do fixation, you see the magic. You see the tremendous magic in the life of the patient and in the life of the family. You see the syringe disappears eventually in 100% of cases. If you have scan after 1 year, if you have scan after 3 months, you will see at least 20% patient syringomalia disappearing. But whether syringomalia disappears or not, 100% will improve in a fashion that you have not imagined in your treatment of syringomalia and carry by decompression. Fixation is the treatment, and syringomalia and carry are children of one entity. That entity is atlantoaxial instability. No problem of the facets, no problem of the instability. Carry is no problem of tight posterior foci. It is anteroposteriorly large, vertically reduced, and like the spinal canal, atlantoaxial fixation is the treatment. These kind of scans, preoperative and postoperative reduction, are a huge number in my department now. And those who are having confusion, please don't keep it. And if you have confusion, there is a very simple option that come and spend some time. Like 314 international fellows have come to my department. I have a list of all this. Even from Egypt, I have got several fellows, and many of you are sitting in the audience. I know it, and they know what is the treatment of Chiari, and they have no confusion. I will suggest, don't keep confusion. Come and I will show you several cases of syringomalia with reduction, and know whether there is reduction or not. Remarkable clinical improvement. Even when there is no bone malformation, the treatment remains atlantoaxial fixation. No bone malformation, but see the facets. See that there is no problem in bones, but see the facet. Even when the facets are in normal alignment, they all indicate the need for atlantoaxial stabilization. And this, I am showing you just images, and then we have introduced several other nomenclatures. Idiopathic syrinx, nobody in the world still knows the treatment, but syrinx is one of the other children, one of the several children of atlantoaxial instability. You treat the father, the child will disappear into wilderness. Atlantoaxial instability is the father of basilar invagination. Atlantoaxial instability is the father of Chiari formation. Atlantoaxial instability is the father of Klippel file abnormality. It is the father of dorsolumbar scoliosis. It is the father of os odontoideum, is father of syringomalia, and father of a number of musculoskeletal abnormalities in the cervical spine, in the dorsocervical spine, and in the lumbar spine. Thank you very much. I have one video to show, but I will show later because I know I have taken too much time. And if you have time for me, I will show you this video at the end of the presentations of Dr. Sarath Chandra and Dr. Sushil Patkar. So thank you very much, my dear friends.
Thank you, dear mentor and teacher, Professor Atul Goel. It was a brilliant presentation, as we are accustomed to. You have learned us a lot and give us an honor to be with us today. Thank you, sir.
Thank you very much. Thank you. It is indeed my pleasure. And I send you my best wishes to your group. I know there are 8,000 people who responded to you for this invitation. And I know there are more than 5,000 members of your society. And I have no doubt that you will make the strongest group of neurosurgery in the world. And I send you and Dr. Sameh my best wishes. And I am sure we will be able to organize several webinars and seminars like this in the coming future. Thank you very much for making me part of it. Thank you.
Thank you, sir. Thank you. And now we will introduce our Professor B.S. Chandra. He will talk to us about CDER technique, operative video, and discussion. Professor Chandra is Professor of AIIMS, New Delhi, India. We are waiting for you, sir.
So good evening. Are you able to hear me?
Yes, sir.
Yes.
Clearly.
So it's indeed a great pleasure to be here on this webinar, and I thank the organizers for having invited me here. So
And today I will speak about my own experience for the past 20 years in dealing with this pathology of CV junction. Now, I do not claim that I have done everything on my own, because I have stood up on shoulders of various people so that I was able to see further. And I would be humble enough to give this acknowledgement to my teachers, which include Professor Chandramouli, with whom I started having an exposure to CV junction. And then, of course, my mentor who introduced me to the science and surgery of CV junction, Professor B.S. Das. And my presentation will not be complete without mentioning Professor Atul Goel, who has inspired me to actually start getting into this pathology. Now, I have a couple of disclosures before I go and describe my technique, which is called as DCER, which stands for distraction, compression, extension, and reduction. This technique is currently registered with a US patent, and we are in the process of creating some customized instrumentation, which I will show you over the period of my presentation. Now, I have been tackling this pathology in a very busy center for the past 20 years, and I have a personal experience of more than 1,000+ cases. And since the introduction of the technique of DCR, I have an experience of more than 200 cases. Now, like Professor Goel has said, it's very important for us that when we get a pathology like this, rather than trying to do a transoral decompression, which incidentally happens to be my surgery more than 10 years ago, we should aim to have a good ending like this, where we are able to reduce and we understand that the CV junction is more like a deformity which needs to be reduced rather than some kind of a irreducible compression. Now, at this point, I would like to say that in most of the physical conferences, Professor Goel would obviously speak first, and this is followed by my presentation. But I had an advantage that Professor Goel would usually get up and leave the room. So I would have no trepidation or apprehension of doing all my presentations, because he would not be there to criticize. But unfortunately, I think here Professor Goel will be hearing my whole presentation, and I hope he will like it. But at the outset, I would like to assure him that my technique has got absolutely no conflict of interest to his technique. So when the C1 arch is not hospitalized, there is absolutely no doubt about it that we have to do Professor Goel's technique, which is C1, C2. What I'm talking about DCR is where the C1 arch is hospitalized and where we have association of severe basilar invagination or atlantoaxial dislocation. And that is where the technique of DCR comes into play, more so for congenital pathologies. So what is DCR? Now, I understand most of the people here, only few of you must have attended my lectures on DCR. And basically, this is an idea which I got by looking at this image of Archimedes trying to lift up the globe using a spacer. So the spacer not only acts like a passive construct in order to reduce the basilar invagination, but it could be used in such a way so that it could be manipulated to actually correct the deformity. And that basically is the philosophy of DCER, which stands for distraction, compression, extension, and reduction. So we have a spacer and we put a spacer, and by putting a spacer, in most of the cases, even though the deformity is corrected, but some of the severe deformed cases, the deformity still remains uncorrected. At this point of time, we apply compressive forces between the OC1 and the OC2, and this leads to a complete reduction of both the basilar invagination as well as atlantoaxial dislocation. And so basically this kind of intraoperative manipulation after putting a spacer is what is the fundamental principle of DCER. So we have a severe basilar invagination, atlantoaxial dislocation with severe deformity. We put a spacer, it doesn't get corrected. We apply compressive forces between OC1 and C2, and this leads to a complete correction. This, in simple terms, is the fundamental basis of DCR. And of course, there are going to be some modifications of this, which we have introduced again. So based on the joint inclination, now we were the first to publish various new joint indices, and this has been published in neurosurgery. And we described a new index called as sagittal inclination, which is basically the inclination of the facetal joint in relation to the line drawn along the posterior part of the dens. So it could be 90 degrees, it could be more than 90 degrees, let us say less than 100 degrees, or some cases, it could be even vertical. So when it is approximately 90 degrees, which is more or less normal, that is where we prefer to do a type 1 surgery, in which case we can do a short length fixation. But when the joint becomes, so this is one of the such short surgeries where, now earlier I used to use translaminar screws for cases where the sagittal inclination was 90 degrees, but nowadays I've stopped using it. I prefer to do a 3-point fixation, whereby I fix the occiput with C2 or C3 or with C3 and C4. And believe me, I have been doing these cases now. I have a huge experience of more than 250 cases. Yes, I did have some complications related to infection or some other problems, but I have never seen a screw pull out from the occiput. So fundamentally, I believe that if the occipital screw is placed properly, it will lead to a very good construct. The two other reasons why I believe that occipital screw is quite good is because in cases where the C1 arch is fused, there is no point of trying to put a screw in the C1 because the entire bony mass is absolutely the same. And third is the liver advantage, which I will come to you a few minutes from now. Now, in cases where the joint becomes more inclined, let us say from 100 to 160 degrees, that is where we introduce the concept of joint remodeling for the first time, whereby we would use a diamond drill and drill the joint surfaces parallel to each other, so that once they become parallel to each other, we are able to introduce a spacer inside it. Now, earlier I used to use these peak spacers, and then we apply compressive forces between a temporary screw on the occiput and then along with the C2, and this converts the spacer into a fulcrum and leads to reduction of both the basilar invagination and AED. So this is how we used to do reduction earlier, and I will show you how we do it currently. Now, what do we do in cases where the joints become completely vertical? So here we have a case where the joints are completely vertical, and it's a 14-year-old boy who is bedridden. Now here we described for the first time a technique called DCR with extra-articular distraction. So what is that? Now, for the first time in the literature, we described that whenever a true joint becomes vertical, so now this is how a normal joint looks like. And when the true joint becomes vertical, the cranium is no more supported by the true joint and the whole cranium sinks inside, because of which there is an articulation between the inferior surface of the occiput with the superior surface of the proximal part of the pars. And this leads to formation of a pseudo joint. Formation of a pseudo joint is an anatomical surety, which means that if you have a joint which is becoming vertical, you will have a pseudo joint. It's as clear as that. So if you have a true joint as shown here, you have a pseudo joint over there. It's only a question of trying to make out the existence of true joint. And once you understand the concept, you will see that this is a feature of anatomical surety, 100% anatomical surety. So again, we have, so in these cases, that's true joint, that's the pseudo joint. So in these cases, we put the spacers, not in the true joint, which is vertical, but in the pseudo joint. So you can see that this is a severe BI with AAD, and we have placed spacers in the pseudo joint, and we were able to reduce it completely. And because the spacers are not within the true joint, we call it as DCR with extra articular distraction. So this is how it looks. We use the same instrumentation, but the place of putting the spacers are different. We put it in the pseudo joints, and then we use it like a lever to reduce it. Now, I always use OAM, and I will show you on some of my difficult cases, challenging cases. Over here, we have a 16-year-old male bedridden, and you can see this is a true joint. It is not completely vertical, but definitely it's becoming vertical, because of which there is a formation of a pseudo joint, and you can see the occiput expanding like a foot plate, forming the pseudo joint. Now, in this case, we put spacers of 7 to 9 millimeters, and we provided compressive forces between OC1 and C2. It didn't reduce. And in this case, Dr. Vincent Trainellis from Chicago was there with me because he wanted to see the procedure. And we increased the height of the spacers to about 10 to 11 millimeters. And then we applied compressive forces, and then we were able to reduce it completely. And that's the pre-op, and this is the post-op. So if adequate correction does not happen with the existing spacers, we suggest that it could increase the height of the spacers, which would provide the just enough mechanical advantage for you to provide optimal reduction of the basilar invagination atlantoaxial dislocation, as well as correction of the deformity. Now, this is a wiring technique which we were using till about 3 or 4 years ago. So since I was asked to present videos, henceforth there would be only videos. So it's a 35-year-old female who had a power of 4/5, and that's the compression. Now you can see that she does have a pseudo joint, even though the joints are not completely vertical, and that's how it looks like. So in this, the first step is we do a foramen magnum decompression. We always remove it, try to remove it as a single piece. And then there is a lot of drilling. We use a diamond drill. And now you can see you have to introduce a periosteal elevator into the pseudo joint and then turn it so that the entire joints become loose. So the most important step of the surgery after foramen magnum is that the pseudo joints have to be disarticulated, loosened out, and released completely, because if this step is not followed, and then we drill the inside with a diamond drill, because if this step is not followed, you will not be able to attain optimum reduction. So you can see how you have to keep on working on it. This takes me at least 45 minutes in complex cases, and one has to spend time in loosening out and disarticulating, because after this, placing a spacer is just a few minutes job. So it's something like a cervical arthroplasty, where the key of the surgery or the fundamental basis of the surgery is preparing the joint surfaces, and that is what we do here. So you can see I'm putting a periosteal elevator and again elevating the joint, cauterizing and removing the soft tissues, using a diamond drill to remove the cartilage inside, putting a periosteal elevator and again elevating the joint so that the whole joint is now disarticulated. You can see that the basilar invagination is now reducing significantly. And that's where we introduce the spacer. These are the special spacers developed by me, which are now patented and will soon come into the market. And we have developed it in collaboration with AIMS and Indian Institute of Technology in New Delhi. So now we make a hole, temporary hole in the occiput, and we put a screw. Now this is only for the temporary basis. I used to do this earlier, but after I developed some instrumentation, universal reducer, I use a universal reducer now, which is a prototype. So we pass a braided stainless steel wire and also pass it through the screw. And then we gently start tightening the wire. Now, as we start tightening the wire, we will find that there is a progressive compression followed by extension happening at OC1 and OC2 joint, and this leads to a complete reduction. So compression, which jams the spacers, followed by hyper extension, which reduces the BI and AD, and this also leads to reduction. And after this, we have to do a standard 3-point fixation, in which case we prefer an occipito C2 or C3 or occipito C3 and C4. So molding the wire. So molding the wire is very important. We provide a primary curvature, which is occipito-cervical curvature, and then we provide two secondary curves. One is a curvature on the opposite side to take care of the occiput, and then a mild medial curvature. That's the medial curvature. And now you can see this kind of curvature, having one primary curvature and two secondary curvature, is important so that the entire spinal alignment can be made. And that's the end of the surgery, where we have fixed, and finally we remove the wire. So it's the same kind of an occipito-cervical fixation, but we use an additional technique by which we are able to reduce the deformity. And this is an anatomical surety. You can go on doing it for as many cases as possible. Now, this you can see is a 11-year-old boy who was bedridden. He underwent some kind of an attempted transoral with a wire fixation outside. You can see there's a practically non-existent spinal cord. And you can see that the joint is again vertical with the formation of a pseudo joint. And this is the wiring you can see. So here we did the same thing. We removed the wire first, And then we put the spacers. Now here you can see that there is the occiput and the cervical spine are almost in the same line. We put a screw here and we start tightening the wire, and now you can find that the angle between the cervical spine and the occiput starts becoming acute, and there is a correction of hyperlordotic cervical spine, which is an indirect reduction, evidence of reduction of the CV junction. And here you will find that it is reduced completely. That was a portion of clivus which was drilled by the earlier attempted transoral decompression. And this you can see a very good reduction with a normal lordotic cervical spine. And this is the pre-op on the left side and the post-op on the right side. You can see the hyperlordotic spine is corrected. And after a couple of months, patients with the DCR undergo solid fusion. Now, these are the spacers which we developed, which are biconvex spacers. And because they're biconvex, they allow the toggling effect or the fulcrum effect, which is the fundamental principle of DCR. And we also developed the spacer screws, which can actually connect this spacers to the rod by means of these special screws so that they can hold the screws very well. Now we went ahead to develop a universal reducer, and I will tell you why the need for the universal reducer came up. So these are examples of putting spacers and which are connected to the spacer screws, which is again connected to the rod here. And this is an example. You can see severe BI reduced with the DCR, but you can see that the spacer is now connected to the rod in a very solid manner. Now, at this point of time, we thought there is a necessity for us to develop a universal reducer, especially for severe cases, because at this point we realized that there is not only a need to do a compression followed by extension, but also a need to push the C2 forward so as to correct the listhesis. So we started working on this kind of instruments with wire, and we found that it was working. And then that's where I went and patented it. And Medtronic became interested to develop a universal reducer. And I will now show you the video of how the universal reducer works.
We present a case of severe basilar invagination and atlantoaxial.
Are you able to hear my voice?
Which was treated by relieving the compression, correcting the
from the video,
and realigning
Yes,
the
it's
spinal
okay.
column using a technique of extraction, compression, extension, and reduction, abbreviated hereby as DCER. This is a unique technique developed by us using a posterior-only approach. During the presentation, we will also be showing some unique implants and reduction devices. These are my disclosures. Clinical details of the patient. A 30-year-old male presenting with progressive spastic quadriparesis. Examination revealed power of 3 to 4 by 5 with a graded sensory loss below C3 dermatome. These are the X-rays with active flexion and extension views, which show occipitalized C1 arch, atlantoaxial dislocation, and possibly basilar invagination. The latter, of course, not clearly made out on X-rays. One should also notice the tendency for the cervical spine to become hyperlordotic in such cases. CT scan of the patient with sagittal reconstruction. This shows severe basilar invagination in the mid-sagittal plane. The parasagittal plane shows severe angulation of the true joint. In order to compensate this, one may notice the formation of a pseudojoint posteriorly as labeled here, which forms between the occipito-cervical foot plate and the proximal superior surface of C2 pars. Pseudojoint is a concept first described by us, and we will describe it a little bit more shortly. This is the CT scan with 3D reconstruction. We do it to look for the position of the vertebral artery. As it can be seen here, it is not present over the joints. MRI shows severe compression of the cord at the cervicomedullary junction. Here I would like to briefly explain the concept of the technique of DCER. DCER stands for distraction, compression, extension, and reduction. It is based on the principle of first distracting the joints using a spacer as shown in the left lower image. This corrects the basilar invagination but not the AAD or the cervical deformity. Following this, compressive forces are applied between the OC1 and C2 as shown by red arrows, and this leads to the correction of both residual basilar invagination and atlantoaxial dislocation. Thus, the fundamental principle to use spacers first as a distractor and then as a fulcrum is very similar to the concept of Archimedes proposing to lift the earth using it as a lever mechanism. The chief indication of DCER is in congenital etiologies, where there is an occipitalization of C1 arch and is especially associated with severe atlantoaxial dislocation and basilar invagination. Since we are using the spacer as a pivot and using the lever mechanism to reduce AAD and basilar invagination, we prefer an occipital purchase and not C1. We have found a 3-point occipito C2, C3 or C3, C4 fixation very good. Enclosed are some of our seminal publications, which we encourage the readers to go through to have a better idea about the concept and the techniques. DCR has been shown in our studies not only to relieve the spinal cord compression, but also corrects the deformity. It has shown to correct the alignment of the entire spinal column. Now here I would like to briefly explain the concept of pseudojoint. We have shown in our studies that as the severity of basilar invagination and AAD increases, the true joint progressively becomes vertical. The weight of the cranium now thus gets supported by formation of a pseudojoint, which is an articulation between the inferior surface of the OC1 foot plate and the proximal superior surface of the C2 pars. The lower image shows the finding which has been seen very consistently that whenever the true joint becomes vertical, the existence of a pseudojoint is an anatomical surety. This slide shows the surgery performed. Foramen magnum decompression, placement of spacers of size 16-18 millimeters, technique of DCR followed by occipitocervical fixation. The patient is positioned prone. I prefer a horseshoe. I prefer to attach a Gardner well traction with just a weight of about 3 kgs. An exposure is made from occiput to C4. As can be seen here, the left fused C1 arch is being drilled. The left C2 ganglion is being exposed. The left C2 ganglion is then retracted superiorly to expose the joint. The foramen magnum is now being drilled. This is important to avoid any cord compression during the reduction maneuver. As can be seen here, the foramen magnum was very deep and causing severe compression. In addition, I also prefer to release the bands. The right joint is now being exposed. I prefer to use a variable impedance bipolar, in this case being from Sutter company, and this provides excellent hemostasis. The next step is to disarticulate the joints. This is performed using a periosteal elevator by first inserting it and then by turning it by 90 degrees. It is important to disarticulate and loosen the joints bilaterally. We are now inserting the specially designed spacers, first on the left side and then on the right side. Since the basilar invagination is very severe here, we progressively increase the size of the spacers till we reach to the final size. It is to be understood that the joints that we are freeing are also partly the pseudojoints. Hence, we also call this technique as extra-articular distraction. We request the viewers to read our papers to further understand this. These spacers are biconvex in shape, hence can slide into the joints easily and are available from sizes of 4 millimeters height till 22 millimeters. They have a hollow cavity into which bone grafts or hydroxyapatite can be filled. We are now placing the C2 pars and the C3 lateral mass screws. The video is shown in 2x speed. We are now showing the reducing system. This consists of a temporary occipital plate, which has 2 components, a wire reducing system and a C2 translator, which pushes the C2 forwards. The wire is made of braided stainless steel wire attached to a special tensioner. In this case, we have used only the cable wire compression system. So here we first fix the temporary occipital plate. Here we fix 2 plates, one small one anteriorly and the other one posteriorly. This allows the compression and extension of OC1 and C2 to take place only in the vertical direction. Now we are looping the specially braided stainless steel wire around the C2 spine and then passing it through the hole of the occipital plate. This is now passed through a crimp and then attached to a special wire tensioner. As we are using the wire tensioner to pull the wire is now tightened between the C2 spine and the occipital plate. One can now notice the superior movement of the C2 spine. Thus, the initial movement is that of compression that firmly impacts the spacers. This is followed by extension between the OC1 and C2 joint, leading to reduction of AAD and also basilar invagination. This is the intraoperative X-ray. The O-arm shows that enough reduction was not achieved, which was expected. So now we remove the earlier spacers and place a larger size spacers. In this case was 18 and 16 millimeters. Increasing the height of spacers also provides a better advantage for the lever mechanism and thus is also more effective to reduce the atlantoaxial dislocation. I prefer to use the periosteal elevator for a railroading mechanism, which allows me to insert the spacers easily. This is now inserting the spacer on the right side. Now, after the large size spacers are inserted bilaterally, we perform the technique of compression and extension at the OC1 and C2 joint using the braided stainless steel cable again. Now we have achieved complete reduction as compared to the pre-op imaging. Now we are contouring the rod to achieve the standard 3-point occipito-cervical fixation. Adequate bone graft mixed with hydroxyapatite should be placed to achieve good bone fusion. Post-operative CT scan shows excellent reduction. We will now show a short video on the use of C2 translator. This is an 8-year-old child presenting with severe spastic quadriparesis. CT scan showed a severe basilar invagination. The true joint, as can be seen here, is completely vertical and the whole weight of cranium is supported by the pseudo joint. There is also a backward listhesis of C2 over OC1 complex. Patient also had an association of a posterior fossa dermoid. So we place the spacers within the pseudo joint, a technique described by us called extra-articular distraction, and then we perform the DCR. In addition, we use the C2 translator to push the C2 forward to correct the listhesis. Here I would briefly like to describe what happens in cases where the true joint becomes vertical and the whole weight is transmitted by the pseudo joint. Now in mild to moderate atlantoaxial dislocations with basilar invaginations, where the true joint is not completely vertical, just a correction using compression and extension techniques with only cable will suffice as shown in the first row. So following compression and extension, the center of gravity, abbreviated here as COG, align completely with each other after compression and extension. However, when the true joint becomes vertical and the basilar invagination is very severe, as in this case, there is also a backward listhesis of C2 over OC1 as shown in the second row. Thus, just compression and extension moments do not align the center of gravities of the OC1 and C2 complexes. Here, we would require an additional pushing force over C2 to move it anteriorly as shown in the last row to align the center of gravities. Thus, in the reducing system that we devised, we use an additional C2 translator as shown by the red down pointing arrow. Thus, by using the C2 translator, we are adding a T to the technique of DCER, Thus now it becomes DCETR, which stands for distraction, compression, extension, translation, and reduction. So in this short video, the spacers are already been placed. The lateral mass screws are already in C2. The occipital plate is in position as in the previous case. We passed the wire as in previous case, and in this case, we have placed a C2 clamp, which I prefer to place in pediatric cases. Now I'm placing the C2 translator, which has the fulcrum over the occipital plate. A screw is now passed through the hole in the structure of the occipital plate. Tightening the screw now pushes the C2 anteriorly. This shows the mechanism of compression and extension being performed by the tensioner and C2 translation which is being performed by the screwdriver. Both the motions should be performed simultaneously, and this allows a complete reduction. In this case, we have used a specially designed spacer screw which attaches the spacer to the occipitocervical rod, thus providing a rigid fixation. Post-operative CT scan shows complete reduction, and the dermoid was also removed in the same sitting using a small occipital craniectomy and endoscopic assistance. Thank you very much for watching this.
So I will end the video just by showing a short clip about the repair of the vertebral artery.
We present a case of anomalous vertebral artery during CV junction surgery, which was repaired primarily. So this is a patient who was a 40-year-old male who was having severe basilar invagination with atlantic axis dislocation. And as you can see, the vertebral artery was over the joint on the left side, and it was anomalous in nature. So here we show you that the vertebral artery was already injured while I was attempting to cut the C2 ganglia. And here I place a cotton directly over the vertebral artery with suction and continue exposing the C2 ganglia because it comes on the way of repairing the vertebral artery. So under microscope, the C2 ganglia is cut completely and the ends are retracted out. And here I remove the cotton, you can see profound bleeding coming from vertebral. It's very important to identify bleeding from the artery as well as the veins. And the veins can be controlled very nicely using a variable impedance bipolar. I prefer a bipolar from Sutter, which provides excellent hemostasis for venous bleeding. And following this, we expose either ends of the vertebral artery and place a temporary aneurysm clip on either side. And again, there is significant bleeding from venous plexus, which again is controlled using a variable impedance bipolar. And now you can see the exposed end of vertebral artery seen very well. So we release the proximal clip to see that there is adequate backflow. And now we repair using 8-of-Prolene. In this case, there was a circumferential tear which was occupying almost 3/4 of the circumference. And I had to use 3 uninterrupted sutures. It's important that in all these cases, the vascular set should be kept ready in case of any inadvertent injury for the vertebral artery. That's the second suture being applied. As told earlier in one of the captions, again, it's important to understand that the anomalous vertebral artery is anterior to the C2 ganglia. So when you're exposing a case with anomalous vertebral artery, you will come across the C2 ganglia first, and you should cut it very cautiously because the vertebral artery is going to be in front of that. So the proximal clip is always removed first. And you can see here that the sutures are holding well. Now I remove the distal clip. The sutures are holding very well out. Now my assistant retracts the vertebral artery using a pencil number 4. And I continue drilling the joint to perform the technique of distraction, compression, extension, and reduction. So the joint is prepared well. And here I'm introducing a trial spacer while my assistant is retracting the vertebral artery. And then this is the final spacer, the core of which is filled with bone graft and hydroxyapatite. So you can see that both the spacers are in situ. This is the final reduction which was performed, and you can see that the basilar invagination has been reduced very satisfactorily. In this case, there was bilateral pseudo joints and the spacers were placed within the pseudo joint. Few tips. Always perform a 3D CT angiogram to look for anomalous vertebral artery. Presence of anomalous vertebral artery is not a contraindication for posterior approach. The vertebral artery may be mobilized before placing spacers. A vascular repair set should always be kept ready. The site of non-dominant vertebral artery should be exposed first. This is an example of a 27-year-old female with severe basilar invagination and cord compression with bilateral pseudojoints. And you can see that the vertebral artery is right over the joint on the left side. So in this case, we performed a successful mobilization of the vertebral artery and we performed placement of a spacer and the technique of DCR. And this CT scan again shows the images before surgery and after surgery showing successful mobilization of the vertebral artery away from the joint. Thank you very much.
So I'll end up my talk with this case. So this is a fracture of dens with severe cord compression. So can we do this from posterior approach, or can we apply the technique of DCR to this? Most of people would not like to do so, but with our experience, we thought that we could do, and this is how it ended up. So what did we do? We went ahead and we drilled the C1 arch completely. So the C1 arch was drilled completely. And we, after drilling it, we placed the spacer between the occiput and the C2. And then we applied the technique of DCR by which we were able to reduce. And I will not show the video because of lack of time, but this is how the post-op correction was. And this is how we fixed it up. So using this technique of DCR, we were able to reduce several displaced fracture, and this paper is now accepted for publication and would be out soon. So in most of the cases, we have had good outcome, but we had a couple of complications also, but these are reducing over a period of time. So summarizing, I would say that basilar invagination is usually because of congenital anomalies, could be associated with AAD. DCR in our experience has been effective, safe, and a reproducible technique to any severity of basilar invagination or AAD. But the fundamental the etiology is that the C1 arch has to be fused with occiput. We described three types of DCR. One, sagittal inclination less than 100, where a straightforward DCR is done, where it angulates between 100 to 160 degrees, where we do joint remodeling, and where the joints are vertical, where we do extra-articular. If you're not able to reduce it adequately, increasing the height of spacers will help. Customized spacers for performing DCR is easy to use, effective, safe, and good long-term outcomes. And our prototype of universal CV junction reducer has, we believe, has made the surgery quite easy, effective, safe. And this was, I presented the technique of DCR all over the world. This was in Korea, where, they inaugurated a special wine bottle in the name of DCR. And it's been a pleasure presenting my work, not only in India, but also outside. And for those of you here, I encourage all of you to send papers to Neurology India, for which currently I'm the editor. And earlier you can see Professor Goel was there, who did a wonderful work as an editor. And for all of you from Egypt, please do send your articles to Neurology India. Thank you once again for giving this opportunity.
Thank you, dear Professor, for amazing lecture. It was an innovative method for disease management. Thank you. And now we will present our next speaker, Professor Social Batkar. He will talk to us about innovations for simplifying craniovertebral surgery. And I want to notify that the discussion will be at the end of session. Thank you.
Uh, his voice is still mute. He has to be told to unmute himself. Sushil,
Please.
yeah, your voice,
Okay.
you have to unmute yourself, Dr. Sushil.
Okay. Am I on now?
Yes, yes, you're on.
So good evening to everybody. I hope everybody remains awake. And Eid Mubarak to all my friends all over the world. And very happy to see my dear friend, Professor Goel and Dr. Sarat Chandra. And the light shining from Dr. Goel's head is really inspiring. The light, coming from his head all over the screen is just fascinating me. So you see, you have seen such fantastic presentations by Abhida, Professor Goel, and Dr. Sarat Chandra. I am going to, I'm going to talk of something different and how to kind of approach this problem very simply. Dr. Goel was very sharp in pointing out that this is a very complex area and you have to be very careful. Otherwise, you can end up in disastrous results. I think this springs was the first kind of craniovertebral surgery, and I think that this was done very simply, and I'm going to show you how I do it. So, what is happening? Why is it? It's not moving, the presentation. So I have no disclosures apart. Yeah, it's all right. So I have no disclosures apart from my teachers from whom I learned spinal surgery, Professor Ramani, most of you must be knowing, and Professor Volker Sontag. And my only gratitude is to my beloved wife, who's my anesthetist for the last 30 years and who works with me. This surgery evolved, like Dr. Goel said, from all this kind of wiring, etc. This was actually, again, Zancoli's concept, trying to control the horse by sitting from, facing backwards. And then you see the predominant movement was rotation. And of course, Magel in 1986 was first credited with this concept of transarticular screws, where he stopped this rotation and had the best 100% results. But of course, there was a rider that in certain cases, the vertebral artery was higher, and therefore you could not pass the transarticular screw. The entire surgery, my dear friends, of craniovertebral surgery, you heard all these stalwarts, is revolving around the vertebral artery and the capacity to reduce the joints back into position. And you'll find that literature is studied with neuronavigation and how to control the vertebral artery, how to repair the vertebral artery, how to mobilize the vertebral artery. Dr. Goel's recent video article on how to mobilize the vertebra. All this surgery is revolving around the vertebral artery. So one thing is sure that Dr. Goel has to be credited. In 1994, 1987, I learned today that he was the first to describe. But unfortunately, I draw your attention to this article where there has been a constant attempt to push down Dr. Goel's name, and still I get surprised when I read articles where this is called as Harm's technique. This is like reinventing the wheel when it was already, invented before in 1994, and then just Harms added a particular screw rod construct and said that this is a new technique. I think we must all push this down. It is Dr. Goel's technique, and remember it as Dr. Goel's technique. But then, in spite of everything, there is always a chance of vertebral artery injury, and there is certain inherent risk to this posterior surgery. Necessity is the mother of invention. Research means search again. If you study the vertebral artery, there you will find, the vertebral artery has got variable course in the facet of the C2, but the fallacy lies in doing the CT scan. It is when you do the coronal CT scan, just, in these images, you make a mistake. There is always dense, compact bone below the facet of C2, which can be used for fixation and which gets missed. So you see people call this as the pedicle. This is not the pedicle, this is the pars. The pedicle is the bone between the facet and the odontoid process. This is the pedicle. This is the pedicle. The portion which connects the facet joints, lamina and spinous process to the body of the C2 is the pedicle. So if you pass a screw under the facet directly into the body, you are anterior to the vertebral artery, and there is no discussion about how to protect the vertebral artery and where is the vertebral artery and whether we have to mobilize the vertebral artery. All that becomes redundant because there is always dense bone under the facet of the C2. So now I will show you some examples. Look at this. There is all we have to do the coronal CT scans properly to find out the dense bone. They should be tilted along the C2 vertebra. Only then you can study the amount of bone available to you. This gives a pseudo impression, but when you tilt the scanner, you will see that there is a lot of bone available to you. This is an example, and you'll see these screws are going divergent. One is going down to the C2 body, and one is going up into the facet of C2, of lateral mass of C1. This is another example. See, when you use the polyaxial screw rod, people struggle to bring the heads just one above. This is not necessary. Once the screws are passed, the heads can even be one above each other. And as long as they are fixed, that is what is important. Now see, this is a case of high riding vertebral artery. If you go right under the facet, you don't have to worry. And you can do the fixation irrespective of the very less bone above the vertebral artery. So this was Dr. Goel's construct. And then I felt that divergent screws, this is the principle of physics. If the screws are divergent, it is a stronger construct than parallel screws. And of course, this got published way back in 2016 with a new entry point, improving upon the technique of fixation and forgetting the injury to the vertebral artery. This got published later on in British Journal of Neurosurgery, Global Spine. But then if you see, Dr. Harms started using polyaxial screws. Even in the lumbar spine, you must remember that polyaxial screw rod construct is always weaker than a plate screw construct. Polyaxial screw rods came because the plate could not be bent sideways. The plate is very rigid as compared to the rod. And we have to remember that the plate construct is always stronger than a polyaxial screw rod construct. So if you want rigid fixation, if bone fusion is a function of fixation, then of course a plate screw construct is superior. And this is the construct which I introduced of manipulating you can manipulate the joint by passing the specialized kind of steppy screws with a plate, and these are VSP screws. So you can reposition the joint by manipulating the screw in the plate. So this was presented as a poster, and then subsequently it was published. And this is the construct which I made. You can see this is a plate with a VSP screw. So you can manipulate the position of the screw in the screw hole and thereby manipulate the position of the joint. And these are some examples. You can see this bone graft, getting the bone graft and eventually getting fusion across the joint. And these are the various types of plates and screws. Some screws with a small fixed size. And if you want to manipulate too much, then I use the screws with the long shafts. There are 3 different types of screws. And the concept is very simple, So this is you pass the screw into the facet of the superior C2 and in the lateral mass of C1, and then you can either put a cage. So this is the Steffi plate, a VSP plate, and you can manipulate this into. You cannot do that with the polyaxial screw rod construct because when you loosen the polyaxial top nut, the implant is mobile. The implant is not fixed. You cannot manipulate that. So. Posterior, this got published recently in the Neurosurgical Focus Video Journal. So for those who are not aware of this technique, I will just show you the video. So if you study, there is always an adequate amount of bone under the superior facet of the C2. And if we pass the screw just under the facet, downwards and medially, you take a midline incision as usual, separate the muscles, etc. Now this is the occiput, this is the C1, and this is the C2. And the joints on both the sides you can see. Now you open the joint. This is the essence of this operation, is opening the joint. This is the lateral mass of C1. This is the par screw. This is the pedicle screw which is passed by Harms. And this is the screw where I pass. I pass the screw just under the facet joint, downwards and medially. Opening the facet joint is the first part of the operation by dividing the C2. I always divide the C2 root, and this is the way to enter into the area just under the facet. There is no fear of injuring the vertebral artery because the vertebral artery is way behind. And this is again the C2 screw on the other side. This is the cadaver in which I am showing it. This is how the screw is passed, and the screw goes downwards, and therefore the screws are divergent and not parallel to each other. It's a basic principle of orthopedics that divergent screws with a plate is stronger than parallel screws with a plate. You must direct your screws in a divergent manner. So you can see the screw going under the facet. So this was the screw which I have described, and I feel that it is very simple. Downwards and medially, there's a large body of the vertebra in the front. Drilling the joint and putting bone grafts into the joint is inherent part of the operation. Then you can use polyaxial screws like in this case, but nowadays I prefer to use the VSP plate with the VSP hole construct. And this was previously I used to use this simple plate screw construct, but I've stopped using this. And now I don't use this kind of plate screw construct. and I make use of the VSP construct like what I've shown over here with multiple holes. So you can reposition the screw in various holes that you want and get the reduction in the position that you want. And then you got the top nut with which, see, remember, a screw with a VSP construct is more rigid than a simple non-locking screw. Now look at this. These are the screws in which you can see the screws have been passed in my direction. One is upwards, the plate is taken over onto the screws. And you will notice that once the plate is in position, you have got a certain amount of leeway in which you can readjust the screw in the plate, and therefore resulting in repositioning of the C1, C2 joint complex. So these are special instrument joysticks made by me, where you pass the joysticks, and these joysticks can be manipulated like this. You can see this, the manipulation, and then at the same time check on the CM that the odontoid is coming towards the atlas by manipulating them. And once this position is fixed, you tighten the top nut in this position. So first you fix one screw in the atlas, the C2 screw is used for manipulation the way you want. And now you will see that I'm manipulating it the way I want, and then I will tighten it in the manipulated position. First, I will tighten the C1 screw in the desired position. Now you see this distance between the plate and the edge of the plate and the screw. Now I will put the top nut, and as I'm tightening, I will move it. By virtue of doing this, I brought the axis towards the C1, and you can see this, there's increased space over here. The screw has been moved upwards, whereby reducing the atlantoaxial dislocation. Now, depending upon the length of the screws and the size of the screws, you decide what kind of atlantoaxial, how much you want to correct, and check it on the C-arm and correct it on the C-arm. Once it is done, you can cut off the extra length of the screws. I also have now, there are screws which are available which do not require any additional cutting, So you get a rigid construct which is in the reduced position. Can you see this? The screw has been migrated and pushed upwards before tightening, thereby reducing the atlantoaxial dislocation. And this is moving as one unit, both the C1 and C2. So this is the divergent concept, where the divergent screw is superior to a parallel screw. See, this is an example of atlantoaxial dislocation which has been reduced and fixed. And the essence of the operation is getting fusion across the joint. This was, divergent screw in presence of a vertebral artery, which is high riding. Anyway, this has been published, and you can see this is free level on YouTube. You can see this article recently. It has come in the month of July in Journal Neurosurgery Focus video article. But then I was not at rest. I felt that the weight transmission in the cervical spine is along the anterior aspect, and fixation should also be in the anterior aspect. The construct from behind is a cantilever construct. It's an indirect construct. When you fix from the front, it is a direct construct. And therefore, if you study the atlantoaxial, bulk of the weight of the skull comes from the atlas into the C2, and very little goes behind into the pedicle of the C2 and down onto the facet joint. Most of the weight is transmitted anteriorly, and therefore surgery and fusion has to be directed from the front rather than from behind. If on extension, the mandible is going above the C2, which happens in more than 95% of the times, it is very easy to expose the C1, C2 joint. This is just like, subaxial cervical spinal surgery. Previously, everybody was doing posterior surgery. Over a period of time, the focus is now posterior surgery for cervical spine is the dying surgery. And you'll notice the amount of muscle. When you go do the surgery from the front, you are only going to detach this much muscle. The longest scoli, nothing more, and the rectus capitis anterior. Your surgery is through the muscle planes. It is not like posterior surgery where you detach the muscles from the occiput, from the C2. You are focusing only on the bones. You have to remember that spinal stability is a function not only of the bones, but also of the muscles. And all the posterior muscles are responsible for holding the neck in extension. By disrupting those muscles, you are adding insult to injury. And in the front, there is a lot of bone available. There is bone available without the vertebral artery coming in your way. There is no vertebral venous plexus bleeding. And you have got the joints in front of you, which you can debride, put the drill inside safely without any fear. No discussion, no necessity of neuronavigation. You just pass the screw on the C-arm, directed towards the posterior upper end of the atlas, and on the anterior towards this point. So you'll find that, this is very simple, and with a very simple screw, or you can use plates. I'll show you some examples, and you don't require a lot of gadgets. This is bang on just a C-arm and a micro drill, not many instruments, just a few screws, and you can use steel screws, titanium screws, and a micro drill, nothing elaborate. You just require a few long right angle retractors. That's about it. I feel that if a surgery looks very difficult, that surgery has not evolved still to the point that anybody can do it. So operation must be simple with as less instruments as possible. So these are some examples you can see. So this is a case of mobile atlantoaxial dislocation, which is fixed with anterior transarticular screws with bone grafts in the joint. And you can see these various examples. Another example of this is reduced. And I started using plates from the front with screws. And you can see these large bone grafts in the joint, which can cause distraction, and plus fusion from the front with plates applied from the front. And another example, and you can put the plate, you can reposition, you can position the graft in a wedge manner so that the atlas is pushed upwards and backwards. And another example, and another example, and another example, long-term. What is this? See this, the incision is under the mandible through muscle planes, no disruption, and you can find that all the neck movements almost are preserved. The posterior muscles of the neck are preserved and intact. They are not disrupted from the occiput, and you can see all the movements are free, and there is no hypoglossal weakness or mandibular weakness. You can see this. See his lip movements. It's a very simple operation, does not require too many implants, and the end point has to be this. If you are not getting this end point, don't get fascinated by implants, don't get fascinated by screws, don't get fascinated by the technique. You have to focus on getting fusion. If you get fusion like this, then you have done the correct operation. Everything else is just discussion, talking about how to put screws, where to put the entry point. If at the end of 6 months, if your X-ray and CT scan doesn't look like this, then the primary operation was useless. You can get complications like this sometimes, when your screw is not in the right direction. Of course, now with navigation and O-arm, the chances of this kind of thing happening is very rare. Here I had not got the reduction properly. Sometimes you get this hypoglossal weakness and marginal mandibular weakness. In the olden times, I used to use implants without locking screws. So sometimes there can be walk out of the screws. Sometimes I had not penetrated the cortex of the atlas, and therefore there was over distraction of the joint. And I know in post-op, the patient woke up with the torticollis. Of course, this was immediately revised. If anybody tells you that there are no complications, that person is lying or has not operated enough. Please remember this very, 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 very clearly. If big surgeons are made on the basis of big complications and a lot of complications, only then you will have a big series. If anybody says, if anybody tells you that, I don't know why I'm having a problem with the battery of this. So there are some complications. Of course, my results were published, and I published my work first way back in 2013 from Japan. This was the first report of putting anterior plates extra retropharyngally on the C1, C2 joints, then subsequently from our journal. Now, these were cases of torticollis where I had a technique where I used to put a lateral mass screw on one side, and then from the other side, I used to put a translaminar screw. But then I went back to the anterior surgery, and I found that most of the patients of torticollis basically have a mal-developed superior facet on one side. Opening the joint, putting bone grafts in that joint, and passing screws can correct the torticollis. And see, this is the result, and see this fusion with long-term result, and the torticollis corrected. Then fracture odontoids attracted my attention. There was, of course, tuberculosis of the C1, C2 joints. You can see this kind of patient would have ended up in occipitocervical fixation. And this patient was operated with plate screw and a transarticular screw on one side to get the position, and then AKT and this healed. And then this was one patient where I had a little deformity after the healing. So fracture odontoid is another thing which caught my attention. So what are unstable fractures where the alar ligament is disrupted? Everybody talks about either ventral screw or Dr. Goel's technique or Harm's technique. They keep on saying from behind. But I feel that the odontoid is not a weight-bearing bone. If there is a fracture in the humerus, you don't do an intramedullary screw for the humerus. You have to do a plate for the humerus. This basic principle of orthopedics, that if there is a non-weight bearing bone, you should not pass an intramedullary screw. And if at all you want to pass an intramedullary screw, then there are certain principles which must be followed. The other thing is that the odontoid changes with age. To advise an odontoid screw for every case, I think is a foolish thing, because the odontoid is not the same in every person. Odontoid fracture in a young person is a very, very severe musculoligamentous injury. And odontoid fracture in an elderly with trivial trauma is a completely different injury. So this kind of odontoid fracture, where the odontoid has gone behind and prolapsed and fallen behind the C2 body, this you cannot treat by either by passing the odontoid screw, neither people end up doing the posterior C1, C2 fixation or going and treating the excising the odontoid process. So I will show you how not to do it. Now, when you pass the odontoid screw, you have to remember it has got a lot of prerequisites. First, that there should be adequate bone in front of the entry point of the screw. The screw should preferably go horizontal, perpendicular to the fracture, and the screw must go into the distal cortex. But tell me, how many of you do the screw like this? Hardly anybody. Then if the screw is not perpendicular to the fracture, this is what happens. If you tighten the screw, it is going to displace the fracture. So your purpose of treating the fractures, there is very, very few odontoid fractures which are ideal for passing the screw. Most of the fractures are like this. This is an odontoid fracture. Somebody has put him in extension, done the screw. There's a gap between the fracture. The screw has not gone beyond the distal cortex. The screw has not gone into the proximal cortex. This is invitation for failure. This is against the principles of bone fixation. And like I told you that the odontoid, you must study the CT scan of the odontoid, and you realize that most of the fractures in elderly are not suitable for odontoid screws. So then I came out with this new technique of passing anterior transarticular screw and repositioning this odontoid back. This is an example. You can see how the atlas has gone back and repositioned and brought back in position, because this fragment moves along with the anterior arch of the atlas. You reposition this back on the C2 body and then pass the transarticular screws. You can get a correction of the position. How to do it, I will show you. This is another type 3 fracture which is going to the facet. It is an unstable fracture. This is not going to heal, and the odontoid screw is useless. This would have ended up in posterior C1, C2. Again, there's a problem to pass the posterior C1, C2 screws. So I started using the VSP plate from the front. This screw is plate is passed on the front with 2 screws, which is fitting with the principle of orthopedics. This is another case where there's a screw which is displayed, the fracture has displaced, reposition it, and over long term, you see the fracture has healed, and you have to get bony fusion. The end point of the odontoid fracture should be fusion of the fracture and not getting impressed by how the implant has been done in the fracture. Look at this. You must get ultimately this kind of cortex which is reformed. That is the end point of treatment. When you get a humerus fracture, if you're going to put 1 screw on top, 1 screw down, and then put a rod outside, that is an external fixator. You should not do external fixator for the fracture. What we have to do is open reduction internal fixation of the fracture. And this is open reduction internal fixation, where you directly treat the fracture and not rely on the implant which is from behind, where it is going to atlas and the fracture is left just like that, or passing a screw for a non-weight bearing bone. This is another example. You can see this fracture, and plus it is going down into the body of the C2. So this is reduced. When you put it in extension, it is not ideal, because when you want to pass a screw, this is the position. It is going back. So this is of no use. It is exposed, and the screw plate is passed, and see over a period of 3 months, the bone has started fusing. It has to fuse. This is a principle of orthopedics. See this is again a posterior displaced fracture brought into position, anterior plate and anterior transarticular screws. So you treat the fracture and treat the instability at the same sitting. There is no need, to treat the odontoid screw, then we will go and do posterior C1, C2 fixation for instability. So this was my construct. Plate from the front with screw in the body, screw going into the odontoid, and screws going across the joint. So new treatment for unstable odontoid fractures. There are 2 types. One is the anterior. This is the VSP concept. You fix 1 screw, 1 close to the edge, and as you tighten it, it is going to compress the fracture. You ask, this is a basic orthopedic concept. This kind of fracture, you can't pass the screw. If you try to pass the screw, there will be trouble. So you pass to put the VSP plate, and as you tighten, it will compress the fracture. This is the treatment of fracture. Fracture has to be reduced and fixed in compression. Now, this kind of fracture, you expose, pass a tap, reposition it, bring the facets in the same line, pass the plate, and then after finishing this, you can pass the transarticular screw. It's a very simple operation, does not require any great technique. Now this kind of fracture, see this is a locked facet. This has to be repositioned, and this cannot be repositioned from behind, it is locked. So how to reposition it? Cut open the muscles. Once the muscles are opened, hold the atlas and reposition it, bring it back into position, and this is the end result. Pass the transarticular screw, freshen the bone surfaces, cartilage, and put bone graft inside, and you can reproduce that fracture. So direct compression, reduction, fixation, a new treatment to treat, a comprehensive treatment to treat any kind of odontoid fracture, early or late, displaced, non-displaced, impacted, non-impacted. All fractures can be treated by this technique. This was published again in 2017. Then also in neurosurgery, no C-arm, no navigation, no vertebral artery injury, simple operation. Of course, then basilar invagination caught my attention. I have my own, I like to do the surgery from the front. Dr. Goel should be credited for this masterly concept of distraction. I feel, but Charu.
So it seems we lost connection of our Professor Butker. Okay, now we start our questions, and we will start questions from our speakers and panelists. So please unmute yourself and start questions.
Hello.
Hello.
Can you hear me?
Yes.
Yeah.
Let's
First
see.
of all, I must audience will get enthusiasm to learn this subject more, and craniovertebral junction is a very important issue. We must learn it, and we must try to imbibe various thoughts on the board, and you should try to develop your own personal experience in this subject. So questions, please.
Is there any questions from our speakers?
Hello.
Okay. Okay.
Yes, go ahead, Dr. Tiwari.
Good evening, sir.
Good evening, Dr. Tiwari. Go ahead, please.
So basically, what happens in malformation of this C1? Many times we see the absence of posterior arch of C1, and we do see this anterior portion of C1. So do you go for C1 C2 fixation in those cases also, or you go for occipital?
See, this is what you are saying is about the bifid posterior arch of atlas, bifid. And bifid posterior arch of atlas is almost always associated with bifid anterior arch of atlas. And bifid, as I am, I am not sure whether I was able to discuss, but bifid is a dynamic process. You do flexion, the bifid opens. You do extension, the bifid closes. So it is an open-close kind of a dynamic process. And this is an indicator of atlantoaxial instability. So whenever you see bifid posterior arch or absent posterior arch, it is always associated with absent anterior arch, and it is always associated with atlantoaxial instability and always an indicator of atlantoaxial stabilization.
Okay. And what do you do for the gliotic part?
What?
For the gliotic part of that junction.
No, I
Can
didn't
you guys
understand.
hear me?
Yes,
Hello?
yes, Dr. Patkar, go ahead. Now we are able to hear you.
Yes.
So I am back. Thank you.
Okay.
So
Go ahead, go ahead.
this was basilar invagination. Last few slides remaining. So this concept of basilar invagination was of course revolutionized by my friend Dr. Goel of being this distraction from behind. And I feel I have my own thoughts about basilar invagination. I think that of course it is related to the sagittal inclination, but also to the coronal inclination of the joint. It is not just simple putting a spacer in this kind of position. If you push a spacer in this, this is going to come back and distract in the same direction. So unless and until the joints are refashioned, and the second function is how much is the coronal incline, the amount of basilar invagination is a function of the dislocation and the coronal inclination of the joint. More the coronal inclination, less the advantage. So there are certain other things which I feel are necessary. When you do this, we have to remember that the atlas slips over the axis in the front. And when you do the surgery from behind, you are going to disrupt all this. These are the muscles which are holding the head onto the external. If you notice that in most cases of congenital craniovertebral anomalies, the spinous process of the C2 is big. Why is the spinous process of C2 big? Because all the muscles are attached to that spinous process and they are protecting the head and holding the head onto the cervical spine. To go and do surgery, to disrupt all these muscles and to do the surgery, I don't think it fits into my concept of correcting basilar invagination. I feel when you do the surgery from the front, there are very few muscles which are disrupted, just a few strands of longus coeli and rectus capitis anterior. So there is 0% risk of injury to the vertebral artery. This was the original implant which I had described using a plate. Where there is a large amount of bone available in the front, without any fear, there is no need to worry, plus a large amount of bone available for you to debride the joints and put bone graft. These are a few examples. You can see this now. And these are the special cages. I feel that to correct, you require a wedge-shaped cage. The cage, if you see, we all learned cervical spinal surgery, applied the principles of lumbar spinal surgery. Realignment of the lordosis is possible only by using wedge-shaped cages with a lot of bone graft in the cages. So you prepared this, pass the wedge-shaped cage, and you can reposition and ultimately get fusion across the joint. This should be the end point, that the joints are getting fused. And if this is not happening, then I don't think any operation is of any importance. You have to see on the coronal that the bone has grown into the facet below and into the lateral mass above. This is necessary at the end. The real story of your operation is at the end of 6 months, 9 months, and not by the immediate post-operative CT scan and immediate post-operative X-ray. At the end of 6 months, you have to be able to show that the joint has fused. That was the purpose of the operation. So these are certain other examples. You can see how the basilar invagination has been brought down. You can see this, and you can see this cage inside and the fusion. And this is another example, anterior facetal realignment for treatment of basilar invagination. See, there were various lines. Now the line which is being talked about is the Grab-Oaks line. That is from the tip of the clivus onto the posterior end of the body, and how much of the odontoid is behind, and that decides the cervical medulla. Dr. Goel rightly pointed out, don't focus on getting complete reduction. What you have to focus on is correcting the strain. If the odontoid moves forward, the strain on the medulla is gone, the patient is going to be better. See this example of Grab-Oaks line correction. Now you can see how the Grab-Oaks has got corrected with the graft inside. This is the concept that this is basic physics. You know, if you got a wedge and if you push the wedge inside, it is going to carry the atlas upwards and backwards. And you all have been doing anterior cervical spinal surgery. It is a simple operation of pushing the cage inside and just putting a plate across. So this got published, first anterior facetal alignment in 2016 for atlantoaxial dislocation. And then neurospine last year, anterior cage distraction. It got published from neurospine, then British Journal of Neurosurgery. So anterior wedge distraction and realignment. And you can, depending upon how much is the size of the cage you put inside, that much distraction you will get. When you do the surgery from the front, as long as the mandible is going up, you can approach any atlantoaxial joint from the front. So this is another example where you can see this is a 9 mm cage, which is the wedge-shaped cage. This is physics. You push a wedge-shaped cage, it will push the atlas upwards and backwards. Nowhere else it is going to go. And then you fix the atlas onto the body of the C2. Then I made use of this spacer, which you can, this is just, I've done just a few cases where I've still not done many cases. I'm waiting for doing more cases. Like I say, that one must wait at least for 1 year before you publish your work. Don't be in a hurry to publish just after doing a few cases. Now you can see this is how from when you do the surgery from the front, you can hold on to the body of C2 and get a reduction by pulling the body in the front, and you can correct the atlantoaxial dislocation. So there is nothing like uncorrectable atlantoaxial dislocation. Now this is another page. This is a more recent. This is just gone for publication. You can see this basilar invagination. From when I did from behind, I found the vertebral artery was dorsal to the pars. And if you'll notice, this basilar invagination is a function of this bone. This bone is maldeveloped, and therefore the odontoid goes up. So I study the joint. See this joint? See the inclination of the joint? You have to study the joint in the center. And then you can see the post-operatively how the joint is, corrected. This is the new implant which I use. This is a special plate which I made for basilar invagination, where one screw goes into the atlas above and these operations, mind you, are done in supine position. So I am at a tremendous advantage over the prone position. Once the patient is in the supine position, you can get what you open the joint to treat instability, to treat deformity, create more instability. Open the joint. More you open the joint, the more you will get correction. And what is the best place to open the joint? It is from the front. And you can see this now, large tricorticate grafts going into the joint. And there's a strong plate which is fixing the atlas onto the body of the C2 in the corrected position. This technique has again got published in Journal of Neurosurgery, video journal, and all those who want the technique is there on the video. This, I think, is a redundant operation. Fixing the occiput is not required. If the line of weight transmission is from the occiput to the atlas to the body of C2, your implant should also be in this same line. The implant cannot be from the squamous bone, a bone on top, down onto the lateral muscle of C2, 3, 4. They have nothing to do with the deformity. So you see this patient, this is when you put a large cage. The problem is anterior, the solution is anterior. The solution cannot be behind. If you see in the lumbar spine, there is a lot of revision now where it comes to lumbar spine surgery. Most of the lumbar spine surgery is now shifting back to ALIF and anterior surgery. Why? Because the vertebral bodies are in the front. If you will see this, now the more and more anterior fixation and anterior cages are coming for lumbar spinal surgery. And if you will see that in very bad lumbar spines also, like spondyloptosis, also the anterior surgery is the one which gives the correct answer. If you see the recent literature in lumbar spine, the trend is towards anterior surgery. Biomechanically, we are at an advantage. This kind of surgery, disrupting the entire muscles from the occiput, removing the bone, I think is just not to be done. So those who are interested in my work, they can see how to demystify surgery for basilar invagination, and plus the technique, how to do it is there on the video. You can see the video. I will not spend time because we're already late. Now I will talk of another last operation which I have described recently. See, the posterior surgery of fixing the occiput onto the spine is like this. You're carrying the head onto the spine like this, when you should actually carry the head in your both hands like this. This is easier as compared to this. So there are situations sometimes where the atlas is destroyed, the C2 is destroyed. This kind of patient who had undergone a bad transoral, plus it had got infected, and there was a discharging sinus down. So this patient came to me in a horrible situation. I have done a new operation where I transferred the weight of the skull onto the vertebral bodies in the front. So you see this is in flexion extension. At the end of 6 months, the screws are holding and the implant is holding. 6 months minimum, not before that. So this is the traditional implant, and this is the new implant described by me from occiput onto the anterior bodies of C2. You can see this is a case of fibrous dysplasia. There's nothing to hold. How to treat this? You would have ended up from occiput down over here. Even the spinous and posterior elements of these vertebrae are involved. And therefore, this new technique of transferring the weight of the skull onto the vertebral bodies into the front. And this is, like I said, there's no point in talking about till you get a long-term result. After medical management, you can see the bone is being reformed. And this was the technique. The technique is pretty simple. There's nothing difficult in the technique. This is atlantoaxial dislocation with basilar invagination. Expose the cervical spine up to C3, which everybody knows how to expose. Remember, lateral to the transverse processes, there is a safe area. There is nothing over here. No artery once you go outside the transverse process. Take the rod, bend it at 2 points at right angles, and let it go in. Just push it through the muscle. It is going to go nowhere but back into the paraspinal muscle region. These are special fixators used to fix the rod onto the vertebral bodies in the front. They are fixed to the vertebral bodies and locked onto it. Then the patient is turned prone. These rods are there in the paraspinal region. You don't have to expose the muscle in the front. Just take 2 vertical incisions on the sides, depending upon where the bone is thickest. Study the CT scan. These are special plates to which you can fix, and then there you can fix this plate to the thickest portion in the occipital bone. And then with a domino retractor, connect this rod. You can reduce this rod as per your requirements, and then connect this rod. And as you reposition this domino, you can reposition the spine and realign the spine. So this is how it looks, the final construct, without disrupting the posterior tension band. Look at this patient. Look at this. Look how the cord is distorted because of this. There's almost no bone available for fixation. And this is the implant. So this, she was bedridden for almost 3 months. And after 2 weeks, she's up and about and walking by this implant, is what she's saying. And she's showing off her movements, etc., etc. So this again got published as a new technique of craniovertebral fixation, occipitocervical fixation, neurological research. So whenever you youngsters are looking at spinal surgery, look where is the force nucleus of that vertebra. See where is the line of weight transmission. See what quality of bone is available. And most important, because somebody else can do it, therefore you can do it, is not correct. The technique has to be safe, simple, and duplicable by anybody else. Only then. Necessity is the mother of invention. Research means search again. No knowledge is original. This is another technique of mine which I've recently published of, there are many cases of rod slippage when you use small rods. So there's a small modification in the rod whereby the rod gets locked into the screws. And now I've started using these kind of rods. So never be happy. Always ask, is there a better way? According to Charles Bronski, sadness is caused by intelligence. The more you understand certain things, the more you wish you didn't understand them. So basically, being dumb is being happy. Don't be dumb, become sad and find better answers. Dunning-Kruger effect. In Dunning-Kruger effect, we begin with, it is difficult. Then you start feeling that you know everything. Then you say that I'm never going to understand this. Then slowly it starts making sense. And finally, you understand, yes, it is complicated, but it is doable. Thank you, my dear friends. Thank you very much.
Thank you, dear professor, for your elegant presentation. And now we will start asking questions. Please unshare your screen.
Dr. Sushil?
Yes.
I want to show you one paper if you don't mind. Okay.
Of course.
Okay.
But how do I unshare my screen?
Are you able to see? You must be seeing my screen now.
Yeah. The severity of basilar atlantoaxial correlates with sagittal joint and coronal joint. Yes. This is
Can
fantastic.
you see the year where it was published?
Yes. Yes.
It is 2014, 1 year before the paper you showed.
Which paper I showed? I've not published anything.
No, not you, but somebody else publishing some.
Yeah, that Chinese paper. That Chinese paper. Correct.
This
I will change that slide and I will put this.
Yes. Now
I will change the slide.
Yeah. Now what I need to mention you is that we did this study. There was a resident. Now he's a faculty at AIIMS Rishikesh. We did this study in almost 300 patients. So we defined the concept, we defined the indices for the first time called sagittal inclination, coronal inclination, craniocervical tilt. And what we found that whenever there is a coronal joint inclination, patients have more frequently basilar invagination and not atlantoaxial dislocation.
Correct.
And they are more prone for formation of pseudojoint. When sagittal inclination happens or increases, it is associated more commonly with both BI as well as AAD. So please do quote this paper whenever you.
I will. In fact, I missed today on one more paper that was by Praveen Salunke, who also described repositioning of refashioning of the joints. But somehow, for most of us, I don't think that these are very easy procedures to be taken lightly. Of drilling the joints, they are not very easy. And then putting the spacers. I agree with you that it is ultimately getting flat joints and getting spacers in flat joints is the answer to basilar invagination. Hello. Hello. Am I heard or not?
Yes, you're heard.
Nobody's talking. You're not saying anything.
I think Dr. Sameh wants to ask some question, but he's still muted.
And even Dr. Goyal is muted. Why is Dr. Goyal muted?
Everybody is stunned.
Yeah,
Pragnesh,
Pragnesh, you want to ask any question?
No, I have got all the answers. I want to just digest the answers now.
Okay.
I am sharing answers now, questions now. Do you see it?
Yes.
Thank you, dear speakers, for your nice presentation. It was a very valuable gift for our Owens family to get this great start by these elegant speakers and mentors. Now we will start to answer these questions. And the first question for Dr. Sushil, the rate of pharyngeal injury in the anterior approach.
So far, you have to remember that this operation is in the nasopharynx. It is high up. There is a lot of muscle in the front, and up to date, I have never had any injury of the nasopharynx because this operation goes, in the prevertebral space, which is a potential space, just like cervical spinal surgery. There is no esophagus there. You are high up at behind the nasopharynx. So there is no question of damaging. In fact, operating on the opposite joint is easier from the right side. It is the same side joint, which is sometimes little difficult. But the whole crux of the operation depends upon the preoperative X-ray. Once you get an X-ray which shows the angle of the mandible is going above the C2-3, this operation is doable. And this happens 5% of times. I agree with barrel chest or with the short neck. It is not possible to approach the joint from. There are many. I think now there is one more. I just saw a name, one Dr. Vinu Gopal from South India, who has also started doing a lot of these cases. There are some in Bangalore. Is Dr. Vinu Gopal on the group or no? I don't know, because I keep on seeing this on Facebook and Neurosurgery Cocktail. He keeps on showing his cases. I'm very happy to see that.
Hello, sir. Hello.
Oh, there he is. There he is. I keep on seeing your work, Dr. Vinu. It's very nice. It makes me happy.
Thank you. Thank you, sir. Thank you.
Yeah, regarding removal of the anterior plate, I've had sometimes, like I showed you in one case, the screw had walked out or the plate had got bent. But now with better and better plates, with locking screws and locking plates, this is not a problem now. The whole function, the success of the implant is selecting the correct implant and is also dependent on the quality of the bone where you're passing the screw. Therefore, you have to do brainstorming on the CT scan to study where you have got dense bone to pass the screw. When you pass the screw in the correct bone stock, you're not going to get a failure. If your bone is going in the wrong area of the bone, you are going to get a failure. On table, after you have finished your fixation, it is necessary to reduplicate the forces of flexion, extension, rotation, and plus move the implant to confirm that the implant is rigidly fixed. If you get out without doing these things, you are inviting a failure of the implant. I hope that answers those two questions which I have been asked.
Okay, sir. Next question for our Professor Goel. Do you use in skull traction for surgery, C1, C2 fixation?
Yes, yes, I always do the entire procedure under skull traction, and I apply the skull traction after the patient is induced, and I remove the traction as soon as the patient is turned back to supine position. So traction is always there, and traction helps even in various other things to neutralize the uh, unstable joint. It also, I keep the head high, so it keeps the venous plexus is little bit light, and it also keeps the head away from the headrest. So, it is almost kind of a floating head. So I always do traction.
Next question, sir. Some may use spacers, some may use cement, some not. Can you tell us when you use spacers and focus on different types if it differs?
One thing is, Dr. Mohammed, always use bone graft, and you use spacers. I had actually, as I mentioned to you, I was using spacers very often earlier. I described intra-articular spacers in the year 2000, means 20 years ago. But over the period of time, my use of spacers has quite remarkably reduced. I have never used any cement, but bone graft is always, has to be, means the bone fusion has to be always there unless you introduce good, not natural bone. All this cement and all these things are unnatural things. Sometimes it may help, and if it doesn't help, the patient's life is destroyed. So you cannot use artificial. Natural bone is always the best. Cement and all these metal implants and all may not be the best. So bone is always the number one. Spacers have some indications like basilar invagination, where you distract and reduce and realign in some selected cases. And I use it now more often when I have a situation where I cannot introduce my C2 pedicle screw. So I use spacer in a very, very rare occasion, more often bone. So that is my answer, Dr. Mohammed.
Okay, so next question from Dr. Schwan. He is asking, do the cervix post-operatively cure completely and after how much time?
Was that, I didn't get the question. Was the question?
Do the cervix post-operatively cure completely and how much after how much time?
Torticollis, you're asking?
Cervix.
Syrinx. Yeah, syrinx. You see, syrinx, whether syrinx reduces or not reduces, that is not the issue. But patient has to improve. That is number one. And syrinx will reduce in about 5 to 10% cases on the next day, first post-operative day after surgery. In about 30% of cases after 3 months, and in 100% of cases after 1 year. So that is the statistics about syrinx.
Is it cured completely, sir?
Yes, it is cured. It is, you see, syrinx, as I mentioned, is not a primary process. It is secondary to atlantoaxial instability. You stabilize the joint, and it is not the question of curing the syrinx. It is the question of stabilizing the joint. So that is the answer. Okay?
Okay, sir. Next question for Dr. Abenda. How to decide patient positioning intraoperative to avoid malfixed craniocervical junction, means in rotation or flexion?
Yes, we position the patient in under traction. We use Gardner Wells traction, and the head is kept neutral or mild extension. So we do not overextend or do not overflex. It is a neutral position. The traction basically stabilizes the head. so that there is remains stabilized in a neutral and mild extension position. And the manipulation is done in the C1, C2 joint basically. And once the head is stabilized and you distract the joint appropriately, you will avoid the malfixation.
Thank you. Next question to Professor Chandra. Is there any special tips and tricks to open the two joint?
See, when the true joint becomes vertical, I don't even touch the true joint. Now, in my latest publication in Neurospine, I mentioned two types of pseudo joints. So type 1 and type 2. Now in type 1, the entire weight is supported partly by the true joint and partly by the pseudo joint. So in such cases, when the joint is supported partly by true joint and partly by pseudo joint, using a diamond drill, the whole joint remodeling can be done, and we can put a spacer in both the true joint as well as the pseudo joint, because the pseudo and true joint, they form a V, and this has been shown to us as a classification of type 1 joint. Now in type 2 joint, the true joint becomes completely vertical, which means that the entire weight is only supported by the pseudo joint. Now in this case, the pseudo joint is just under the occiput, and it's very, very easy to access. You just have to open it, and sometimes you'll be amazed to find that there is even articulating cartilage, there is also articulating fluid, but this is all pseudo joint, and you'll find the occiput to be expanded like a foot plate, and the lower part of the occiput articulates with the proximal superior surface of the parts of the C2. So in these cases, in the type 2 pseudo joint, we put the spacer completely only in the pseudo joint or the false joint, and then we perform reduction. That is why we call this technique as a DCR with extra-articular distraction. See, when we have introduced the technique of DCR, there are a lot of congenital malformations, everything which we have completely excluded, and we simplified the whole process. So if the C1 arch is not fused, there is no doubt about Professor Goel's technique. You have to do a C1, C2 fixation. There is no need for you to put a spacer. You can put a bone graft, that's excellent fusion. But in cases when the C1 arch is fused with occiput, there is severe basilar invagination. I did try to put bone grafts in a couple of cases, but when we put a bone graft and then when we try to do manipulation like the compression, the bone graft collapses. Because of which I believe that we have to put a metallic spacer, and I'm talking of very serious cases, very severe cases. Now in the spacers in between, there is a hole and we put bone outside. And like I've shown in my in one of my slides, once there is immobilization, you put a bone, there is a solid bone fusion. And after 6 months or 7 months, you find that there is a solid bone plate which has developed over that area.
Thank you, Steve. We have here last question. Which is your experience with open field MRI for the dynamic evaluation of stability in craniocervical junction pathology? It's open for you.
So now in our place, we do a CT scan with 3D and a CT angiography. And in our experience, a CT scan provides you an excellent information regarding the instability. There is no need for us to do either flexion or extension because that's pointless. The most important thing is you need to see the anatomy of the joint A and the relation of the vertebral artery to the joint. These are the two most important things which have to be. There is absolutely no role of flexion, extension, X-ray, and all those things. MRI is useful to look for any soft tissue anomalies. For instance, there is a syrinx or not, and what is the degree of compression on the spinal cord. So the joint, everything is done by the CT angio and the CT angiography, and that is what helps us to plan surgeries. I'll be happy if Professor Goel can give his own viewpoint here.
Yeah, you see, you know what, as I mentioned, as I showed, you see, investigations are very, very important to do good investigations. Like you also work in a public hospital. I am also working in a public hospital. You cannot say that, okay, let me just do with MRI. You cannot say, let me just finish with the CT scan. We have to do complete investigation, and all the investigations where we are convinced that vertebral artery is here, vertebral artery is taking this kind of turn. So our investigations have to be complete and elaborate. We cannot compromise on investigations. As I mentioned to you, that recently for very, very complex cases, we are making 3D models. And our radiologist, who is one of the very, very fantastic radiologists of our country, they are making these models on a material which we can actually sterilize and keep it on the operation table. And these you can see where is the bone and how to introduce your screw, and all those things can be very eminently and elegantly seen, and you can do during operation. So this is my recent favorite investigation for more complex cases.
Last question is for Professor Batkar. Do you use spinal endoscopic in the retropharyngeal space to approach C1, C2 joint?
With the endoscope, you can approach the joints, but to manipulate the joints, to debride the joints, to fix the joints, endoscope, I think, is still very primitive. You need to expose the joints properly. You have to use, you must see them on the microscope. You must see the joint, debride the end plate, put the drill inside the joint. I am sure with passage of time, all procedures progress towards minimalism. And there will be endoscope will come into use for doing the surgery from the front. But at this point in time, I have no experience of using endoscope in the retropharyngeal space because I feel there is a lot of manipulation required over there and a lot of debridement. I don't think endoscope was tried even for posterior surgery. Even for posterior fixation, people have talked about percutaneous fixation. But I don't think that compromises the principle of joint manipulation and joint fusion.
Thank you, sir. And now we are waiting to Professor Atul Goel to share his screen to see his own video. Thank you, sir.
I think, you know what, we have seen enough videos now, and I will show you on the next occasion. I think it is, there's no point in, having some, you want to see it? Okay, let me see if I can, because I have closed my screen. Unfortunately, just let me see if I can reopen. I think I have, lost that presentation here. Dr. Samay, I think we ignored that because I have closed it, and I will have some difficulty in hunting that. Okay?
Okay, sir. We have one question here for Dr. Social for anterior C1, C2 fixation. You go right side exposure always. Do you find difficulty in retraction due to mandible? Dr. Social, are you here?
Yes, I can hear you now. Hello, can you hear me?
Yes, sir. Yes, sir.
Okay. So the question was whether I operate from the right side, correct?
Yes, sir.
Yeah, I always operate from the right side. I'm right-handed surgeon. So if I'm right-handed surgeon, it is easier for me to stand on the right side and operate like you do a cervical spinal surgery. So there is no question. Operating on the from the right side is easier for a right-handed surgeon. If you're a left-handed surgeon, then you must operate from left side.
Okay, so thank you. Thank you, all mentors and speakers. Is there any questions from speakers or panelists? Please unmute yourself and ask it.
On the behalf of neurosurgical.tv, I'm really thankful to you all for the wonderful lectures, and especially Professor Atul Goel, who is a big inspiration for all of us, the neurosurgeons, especially in Pakistan. We usually follow your guidelines in the cervical vertebral, the cervical occipital CV junctions, and I think that it is a huge contribution of yours during this COVID-19 pandemic for us to learn more about this such surgeries and to learn all the tricks. Thank you so much, sir. We are really grateful to you for that. And also Professor Abida Shah for her contribution. I'm really honored. And all the other ones, Dr. Sushil Patkar and Dr. Sarat Chandra, and a huge thanks to Dr. Sameh Al-Mursi for arranging such a wonderful webinar, and also for all his contributions in the Telegram group. I want to just announce that all the recording will be available on neurosurgical.tv app, as well as neurosurgical.tv YouTube channel. So kindly, if you have missed out, or if you have got friends who have missed out, or if you want to go through again, which we highly recommend, then please do join those channels and the apps to go through it again. Thank you so much again, and thanks for letting me speak. Thank you.
Okay.
Thank you. Thank you very much. Thank you very much.
Thank you so much.
Bye to everybody. Good night.
Bye bye.
One more point, sir. I'd like to apologize about our dear moderator, Professor Fauzi, because there was some internet connection problems. And also, I'd like to unmute our dear colleague, Dr. Akal Gupta, to thank our dear speakers because of his great effort in organizing such great event. And thank you all. Dr. Akal, are you here?
Yes, thank you, Dr. Sameh. I feel humbled to be a part of this webinar and thankful to my mentors for being here with us. Definitely this webinar was full of knowledge and was rich with experience of Master of Masters. Thank you. Thank you so much. Thank you, sir. And good night to everyone.
Good night. Thank you very much.
Good
Thank you
night.
all.
Good night. Thank
Thank
you,
you.
Samay. Thank you, Achal. Thank you, Noor. Bye-bye.
Thank you, Arthur.
Thank you, everyone.
It was a great to meet you all, and we will share this video in our Telegram group. Please do more effort to get more great events like this. Thank you all. Bye-bye.
Thank you. Bye-bye. Bye-bye.